Good morning, and I'm very happy and excited to welcome you all to this fifth event of the MSF Pediatric Days. This year, we have had more than 1,350 delegates register for this conference, and that is fantastic. We're joined on this platform by people from all over the world, as you can see on the platform's networking lounge. I am Myrto Schäfer, and I'm joining from Greece. I will be the moderator for today's event. Before we start, I want to take a moment to thank MSF Sweden and MSF OCPA, who are the sponsors for this event, and without whose support it would have been impossible to hold this and all previous and hopefully future pediatric days. Thanks so much. Now a few words to the title of the day, Together for Better Care. While the session after the break on zero separation will be exclusively on the mother-baby pair and family-friended care, the rest, and particularly the first part of all the morning, will also take into consideration the larger picture. It will try to showcase how multifaceted the approach to infant care needs to be. Good care can only be achieved if we take into consideration the context, build responses that are contemporary and comprehensive, responding holistically to the children's needs. It is about looking at health delivery systems and how to work collaboratively within the system and with the stakeholders around us. What equipment is needed and how we can best be trained and how we can provide the best possible training. What are the resources needed? And how can we extend care beyond the walls of a physical health structure and provide a quality continuum of care? Best results can only be achieved if we integrate context-adapted psychosocial and mental health care with physical care and interventions. We need to start with the right mindset, use expertise, experience, and knowledge around us, and implement programs within and together with the communities we work for and in, and then monitor and follow those up with evaluations to feed back into further improvement of our care. And we must advocate for those who do not have a voice and share our successes and lessons learned. So today we will hear about experiences on how to better implement care together. We will hopefully have the opportunity to exchange on our own experiences and walk away inspired and with new ideas on how to translate some of what we have heard today into action. A few words on housekeeping. I hope you all had the time to familiarize yourself with the virtual platform and had a chance to watch the introduction video. If not, you will find it at the help desk on the homepage. Apart from listening to the presentation from the auditorium today, where you will be spending most of your day, you can use the other interactive functions and visit the virtual rooms during the breaks, go to the booths, meet other delegates, look at posters in the poster hall, and use the resource library. You can post a picture at the photo gallery, particularly if you're watching as a group, and you can post on the chat and say who you are and where you're joining from. Most of the functions will be available for a couple of weeks after the conference, so you can use your time today to follow the live event. If you have joined the meeting with a bigger group, please register individually. That way we can later see how many people participated and from where. And you will be also able to use all the other interactive features like questions and answers, conversations over coffee, etc. At the end of the day today and at the end of the third day, there are workshops. Those of you who have registered, please make sure that you check your email so you know how to join and to your respective workshop. So without further ado, I want to introduce our first speaker of the day for the opening address, Maria Guevara. Maria is a pulmonary and emergency physician and holds a master's in global health policy from the London School of Hygiene and Tropical Medicine. She started her humanitarian work almost 20 years ago in 2004 in Liberia with MSF. Maria has held a long list of different senior positions in MSF and with WHO. Previous to her current position as MSF's International Medical Secretary, she was Senior Advisor on global health and Senior Coordinator for attacks on healthcare. Maria, welcome and thank you. The floor is yours.
Thank you, Myrto, for the introduction and the warm welcome. Greetings from Geneva. In return, I also welcome you all online, wherever you may be connecting to this fifth edition, second virtual edition of MSF Pediatric Days. It's quite amazing that this conference or event, which started out, which started out back in 2014 as the seed of an idea in returning MSF field staff. So they were driven by an instinct and the wish to provide more than just resources, but true support in improving the quality of pediatric medical care in MSF missions. This seed became a reality as the first ever MSF Pediatric Days in Stockholm on September 2016. It was attended then in person by 180 participants. And while live streaming had always been part of this setup, it was not until last year when it became fully virtual, so reaching so many more people, sharing the wealth, so to speak, with more than 1,000 participants all calling in online. And today that's the same case, and saving carbon at the same time. Bravo for this. To me, this seemingly simple act of connecting virtually, and not to underestimate the incredible planning and organization that goes on to make this happen, are important steps to the what and how we need to be considering as new ways of working. As we look into the future, learn from COVID, and push ahead in a globally warming world. And this simple act also provides an important opportunity to bring visibility to share experiences on, and to learn from each other about the critical action of medical care in humanitarian settings, specifically pediatric care, through the MSF lens of the past, at the present, and into the future. So let's start in the past. Who are we? Where have we come from? And why are we here? In December 1971, MSF was born in the wake of the Biafra Secession War in southern Nigeria, where the Biafran people were decimated by famine, with children dying in numbers from hunger. The instinct and wish to do something were already there. In a group of young doctors who decided to go and help victims of wars and major disasters and bear witness to the horrors these victims were going through. For them, it was a simple act of going where the patients and the needs were, to quote Bernard Kouchner. It's simple, really. Go where the patients are. Seems obvious, but at the time it was revolutionary. We wanted to ensure sufficient knowledge of this new type of medicine. And with that, MSF became the first international humanitarian organization that specialized professionally in medicine. In December 2021, MSF turned 50. 50 years of providing humanitarian medicine in the most challenging, hard to reach, and conflict-ridden settings, driven by medical ethics and humanitarian principles. In between these milestone dates was that of 1999, the year MSF was awarded the Nobel Peace Prize, which provided the funds for the creation of the Access Campaign for Essential Medicines to address the political, economic, and legal barriers to patients' access to life-saving treatments. Driven by the growing experience and frustrations of feeling powerless in the field due to the lack of quality care in essential medicines, coupled with rising drug resistance to treat infectious diseases as malaria, TB, meningitis, sleeping sickness, other NTDs. This represents the clear action of pushing for equitable access to quality care and waking the world up to the inequity that exists. Again, the instinct and the wish to do more and better were there. Now, coming to the present, where are we today? In numbers, in 2021, MSF reported running 893 projects globally, 55% of which were in unstable or conflict settings, with a workforce of nearly 50,000 staff, which began at 300 in its early days. MSF field teams provided 12.6 million outpatient consultations with 1 million inpatient care, 2.7 million malaria treatments, 1.6 million measles vaccination, 82,000 treatment for severely malnourished children, over 300,000 assisted births, including cesarean sections. That's just to name a few. In quality, this is a bit harder to show, but work is definitely ongoing to ensure a quality improvement process is in place, enforcing a culture shift to a shared approach to quality care. What we do see, however, if we are to link it to the main objectives of this pediatric gaze, are one, an important and constant growth these last few years in inpatient pediatric and neonatal care. In this last year, pediatric hospitalization represented 42% of global volume, with neonatal hospitalization making up 5% of that 42%. This highlights the increasing capacity in this field, especially in conflict areas, probably much thanks to all these kinds of exchanges that is happening in this event. A shift also in HIV care to the more neglected regions and populations, meaning an increased focus on pediatrics and adolescents. A push for a more multidisciplinary approach to break the silo between provision of care for the mother and that of the child. And those progress includes collaborative work between the different working groups as the lab, the TB group, the HIV group, with the pediatrics, as well as the maternal health group, on a number of areas from chronic care guidelines to developing shared priorities and clarification of diagnostic algorithms. There's been a growing focus on more community-based, or rather community-led approaches, as with operationalizing the integrated community case management approach. There's been an expansion of malnutrition treatment to include more and more the care for moderate acute malnutrition along with the SAM cases. And there's been more active work on medical advocacy as with not neglected tropical diseases, whether from snake bites to Noma, the latter of which you will have the honor to listen to Mulikat, Noma survivor, to give her testimony on day 3. All these improvements are and will prove ever more critical as we look to the challenges ahead, which brings us into the future and what lies ahead for us. Sadly, it means more challenges, more emerging threats. And COVID was and is, as it continues to trot around the globe again and again, our dress rehearsal to what lies ahead, showing us our inseparability and our collective unpreparedness, and continues to remind us of a new frontier of fragility and vulnerability. That also means the crisis of tomorrow, not only where we go in a spirit of solidarity to save lives in traditional, quote, humanitarian hotspots, but it will also be in the developed world, the so-called North. But while COVID wreaked havoc in all corners of the world, it remains very clear the impact of COVID has been disproportionately and inequitably borne by certain populations and countries as we face the ethical dilemmas of field reality, not being able to provide the novel vaccines the rich had access to. What can we take home as lessons to ensure more equitable access to quality treatment and preventive care for the next pandemic? As it is almost a given that COVID is not a one-shot. With biodiversity loss, climate change, and land degradation going unabated, it will just be the first of many. Let us hope it is not, but there is no doubt that climate change exists, and tomorrow you will be hearing from Dr. Bhutta on this. But as an intro, according to the 6th assessment report of the Intergovernmental Panel on Climate Change, the verdict is grim. It means the planet is no doubt heating at a rate never seen before, and it is our fault. Yes, us humans. And there is little hope remaining of avoiding a worst case scenario. The effects of climate change will be overwhelmingly negative, with the most vulnerable being the most impacted. And those vulnerable groups include indigenous populations, local communities, the elderly, women, and of course, the children. Highlighting clearly the climate crisis is a humanitarian crisis. The report also unequivocally links climate change to negative health impacts, from extreme heat causing increased disease and death and more frequent and more severe extreme weather events, to increasing incidence of foodborne, waterborne, and vector-borne diseases, definitely more malnutrition due to rising food insecurity, the emergence of new infectious diseases, especially the animal origin as with COVID, or even a rise in chronic diseases, on how climate change and environment degradation contributes to violent conflict and population displacement, and then for the first time, mentioning how mental health is negatively impacted by climate change. Again, the climate crisis is also a health crisis. Having just come back from COP27, where the discussions on loss and damage has finally come officially to the table after 28 years of meeting, there were some wins and some losses. To just quickly explain, the UN climate negotiations approach on loss and damage is in 3 distinct ways. 1, averting loss and damage, meaning reducing greenhouse gas emissions, minimizing loss and damage, as with assisting people and communities to adapt and prepare to the extent possible. And 3, addressing the loss and damage by dealing with and recovering from the consequences of the climate impacts, which is happening today in our fields. While there continues to be a battle on truly committing to facing down on all fossil fuel use, an agreement was reached to create a loss and damage fund. And for the first time, health issues made its way into the official document with a reference to the right to a clean, healthy, and sustainable environment. But the more poignant and tangible outcomes of the COP are actually the people and the advocates present fighting for social and climate justice. Hearing Rosamond Adu-Kisi Deborah, ambassador for the Brief Life and mother to Ella, her 9-year-old daughter who died from repeated asthmatic attacks, and whose death certificate officially states that air pollution contributed to her death, the first ever reference, tirelessly pushed for the right policies to be in place, and succeeded to have Ella's law bill passed that establishes the right to clean air in the UK. For Dr. Arvind Kumar, leading cardiothoracic surgeon in India, and of Doctors for Clean Air, passionately pleading for climate action, as he shows us pictures of the black lungs of a newborn baby he had to carry out surgery on. At MSF, we are working to understand what climate change and environmental degradation means for us, and how we need to address the impact on the populations we serve. For some, we use the framing of planetary health approach, viewing health within an ecosystem where human health is interdependent and inseparable to that of Earth health. We are also framing our actions through the 3 pillars of operational adaptation, along with operational research and anticipatory action, as with the Malaria Anticipation Project, the footprint mitigation as through establishing carbon roadmaps, and advocacy as in building knowledge and adding rules to climate literacy. But we are only one cog in the wheel of humanity doing medical humanitarian work and addressing the ever-increasing, compounding, complex, and cascading emergencies that are already in the present and that will only get worse in the future before our whole village, whole of society working together in solidarity. All this is simply to say the richness and the value of exchange held in an event such as this cannot be overstated. The collaborative efforts of learning from and between every experience of each contributor on best practices, the links and connections made are born from the instinct and the wish to do more and better. This is precisely where we can take the next steps together in ensuring that the future of pediatric care and humanitarian medicine at large means simply good, quality, equitable, and sustainable medical care. Thank you for your instincts and the wish to be here today. Wishing you all a great and productive conference. Thank you.
Thank you, Maria. Thank you so much. Now we will start our session with the oral presentations. Before we start, a short word to timing. The oral presentations are 7 minutes long. After 5 minutes, there will be a short bell tone to remind the speaker that there are only 2 minutes left. And after 7 minutes, the final double bell will ring. After the presentation, there will be 3 minutes for questions. Please put your questions in the Q&A box and not in the normal chat box. Thank you. So our first speaker is Nieves Amat Camacho. Nieves is a nurse with clinical and global health experience with MSF. For 7 years, she worked as a researcher at Karolinska Institute in Sweden on health preparedness and response to emergencies. She is currently working on her PhD in Italy, focusing on infant feeding practices in humanitarian contexts. Today, she will talk to us about breastfeeding promotion and support in Maiduguri in Nigeria. Thanks and welcome, Nieves. Looking forward to your talk.
Thank you so much, Mirta, for this introduction, and good morning to everyone. It is a pleasure to be here today to present our study, which looked at breastfeeding promotion and support in Northeast Nigeria. So to give you a bit of a background, it is recommended that breastfeeding is protected, promoted, and supported for all infants in emergency settings, where access to safe breast milk substitutes, potable water, and hygiene is often restricted, At the same time, the establishment of exclusive breastfeeding is considered a central part of the management of malnourished infants under 6 months. Still, in spite of the importance of this topic, very scarce literature currently informs about the feasibility and effectiveness of breastfeeding promotion and support in humanitarian settings, or how those are perceived and accepted by caregivers in such complex situations. Thus, the aim of our study was to explore caregivers and health workers' perceptions and experiences of breastfeeding promotion and support in the context of an MSF OCB nutrition project run in Maiduguri, northeast Nigeria. This setting has been affected by a conflict for over a decade and is shaped by recurrent epidemics, population displacement, and food insecurity. It is estimated that only 29% of infants are exclusively breastfed in Nigeria. The project we focused on in Maiduguri provides ambulatory and inpatient care for malnourished children with a dedicated ward for infants under 6 months, as well as outreach health services in 10 informal IDP camps. Within this project, breastfeeding promotion takes place in the community and at the hospital, involving community health educators and health promoters. Breastfeeding support during admission of malnourished infants under 6 months involve frequent encouragement of breastfeeding, assistance on breastfeeding technique and breast stimulation, and appropriate nutrition and rest, as well as mental health support. Data collection for this study included in-depth interviews, focus group discussions, and non-participant observations. A total of 32 participants, as shown in the figure, were recruited at MSF facility, both ATFC and ITFC, and in one IDP camp. The data was analyzed using reflexive thematic analysis, directly from audio recordings. In terms of participant characteristics, interview mothers were mostly illiterate and generally grand multipara. None of interviewed caregivers with malnourished infants were providing exclusive breastfeeding on admission. Our results, summarized in this thematic map, re-emphasized that breastfeeding practice does not only rely on mother's knowledge and wishes, but it was experienced, encouraged, sustained, or discouraged by the family and the community. We found a widespread perception of breast milk insufficiency, often related to poor maternal nutrition and emotional stress, or triggered by inadequate breastfeeding practice or maternal illness. As a response to this perception, most families directly provided the supplementary feeding with affordable liquids or foods instead of looking for breastfeeding support. In terms of breastfeeding promotion, communities seem generally open to breastfeeding promotion messaging, and families were willing to uptake recommended practices. Identified enablers for behavior change included involving key community members, traditional healers, and family members, and using examples of successful cases within the community. Health workers still felt that breastfeeding promotion messages were sometimes quite generic and did not always target specific issues addressing the causes of suboptimal feeding practices. The provision of breastfeeding support as part of the management of malnutrition presented some challenges in this context, including mothers' expectations of formula provision on arrival, cultural differences, including languages, different languages and gender issues, mothers' vulnerable emotional status on admission, and a prolonged length of stay. Health workers also highlighted some difficulties around infant formula supply, for example, a lack of established solutions for mothers who were not wishing to breastfeed. Despite challenges, mothers usually accepted the breastfeeding support and follow recommendation in the ward, often thanks to the encouragement from mental health counselors and other mothers, peer support. All interviewed caregivers felt grateful for the comprehensive care provided, included breastfeeding support, and the positive results achieved in both their infants and themselves. On the other hand, most participants feared that the achievements of breastfeeding support gained in the hospital could decrease or stop after discharge when mothers lack access to enough food or constant support. Health workers recommended to improve ATFC ambulatory care follow-up for infants under 6 months and to increase the community management of these infants and their mothers. This study obviously had several limitations, most of those linked to the nature of qualitative research that were tried to be overcome by triangulation and other ways. Still, we can conclude that breastfeeding promotion messages need to be tailored to specific breastfeeding barriers. In this context, particularly focusing to address perceptions of breast milk insufficiency, which in this setting is closely linked to poor maternal nutrition and other contextual factors, these perceptions. The provision of breastfeeding support among caregivers of malnourished infants is well accepted in this setting and seem to lead to improved practices. Yet, future quantitative research is needed to assess the real effectiveness of breastfeeding promotion and support to change breastfeeding practice, and whether these changes are sustained over time or not. Thank you.
Thank you so much, Maria Nieves. That was so interesting, because one of the things that I find particularly interesting and important is that we move or we join qualitative research to quantitative research. Too long have we just relied on quantitative research, and important to see how the community needs to be engaged. You very clearly stated that a lot of our work and emphasis needs to be on further work in the community, and it needs to be tailored specifically and not be generic, if I understood you correctly. Could you please maybe give a couple of examples of how this could be tailored specifically to the mothers? And you also talked about the healers, traditional healers, etc., how this was done, how you included them. Thank you.
Thanks for your question. So yes, some examples, as we know, the reasons for feeding practices, the determinants for different feeding practices are multifactorial, and sometimes we are targeting some causes, but it's not the cause that particularly affects this woman or this community. So in this case, for example, there is a very extended perception that mother's nutrition will affect breast milk and breast milk production. So it's very important that in this context, these messages are clearly given to mothers, understanding their nutrition situation in the community. So they know, they have the information, and they can do according to that. But generic, often their perceptions overcome knowledge. So even if they know what practice is best or is recommended, they need to understand how to undertake that practice in their situation, in their context.
Mm-hmm. Yeah, thank you very much. Thank you very much. I'm just looking if there is any other questions from the audience. Please don't forget to put, or it might be a little bit unusual, but put your questions in the Q&A box so that I can see them, and then I will ask the questions orally. I will speak to the audience. I'll be your microphone if you want. Just one last question: how does what you found in your research compare with the global research on that topic? I imagine, although there might be not that much, there will be some research on that topic. Thank you.
Yes, thank you. Yes, indeed, the issue of these perceptions of breast milk insufficiency, it's very standing, and it is one of the main reasons preventing exclusive breastfeeding among mothers worldwide. This is very general, so it's really something that we should put an effort on, because it's quite global, and we will find it in many MSF contexts. And yes, there is not so much research, but also in food insecurity settings. These perceptions of maternal nutrition affecting the breastfeeding, or even their stress. They feel emotional stress due to the displacement, the loss of livelihoods, the struggles in life to look after many children in this situation. This is also preventing them to feel capable to breastfeed their infants.
Sorry, I was muted. Thank you. Thanks again, Nieves, and I look forward to further research to that topic. That is so important. Okay, so now we move on to the next presentation. Our next presenter is Karine Leroc. Hello, Karine. Karine is a clinical psychologist with a PhD in psychology, and over the last 25 years, she has been coordinating and implementing mental health and psychological support networks and child protection in humanitarian contexts all over the world. She currently oversees research programs to maternal and mental health, related to maternal and mental health, early childhood development, and child undernutrition for Action contre la faim, or Action Against Hunger. And she does that in collaborations with academic institutions in France, the UK, and the US. Karine will talk to us about experiences with child-friendly spaces in Cox's Bazar in Bangladesh. Welcome, Karine.
Thank you, Myrto, and good morning, everyone. So on behalf of the two other co-investigators, Sarah Murray and Amanda Nguyen, as well as our team in Bangladesh, I'm glad today to present our scientific evaluation of psychosocial impacts of baby-friendly space that was implemented in Cox's Bazar in 2021-2022. This study concerns Rohingya refugees living in camps located in the southern part of Bangladesh. In these most populated refugee camps in the world, living conditions are harsh and the population's well-being is frequently challenged. Why is this study essential in this context? First, because there is lack of evidence of low-intensity psychosocial programs for maternal mental health. Second, because we need to assess the risk that poor maternal mental health poses to child growth and development. And third, because we need to get more feedback from service users in low-resource context. Now the intervention. Baby-friendly space is a humanitarian program that was developed by ACF for pregnant and lactating mothers with their 2-year-old children. It aims at improving mothers and children well-being through participation into tailor-made activities that promote breastfeeding and childcare practices, reinforce mother-child bonding, allows quality time for play and child stimulation, and offer self-care for mothers. Based on this set of activities, we developed a curriculum with 5 modules integrating psychosocial stimulation in nutrition through baby massage and hygiene practices, in baby play and breastfeeding. An additional session was designed for mothers in need of individual psychosocial support. The intervention lasted 8 weeks, and the mothers could attend each time they would come to the nutrition consultation with their children. To assess the effectiveness of the intervention, we chose a randomized control trial design. We selected 10 baby-friendly space centers that we randomized by pair. In 5 intervention centers that we call the Enhanced BFS with implementation support, the staff was retrained in the new curricula of activities presented earlier. And the 5 control centers, the activities were conducted as usual that we call standard BFS. Regarding the outcomes, for the mother's psychosocial outcomes, which were our primary outcomes, we measured psychological distress, functional impairment, positive coping, and subjective well-being with the different questionnaires that you can see on the screen. Regarding the children, we measured developmental delay as well as weight, height, and mid-upper arm circumferences. We also assessed child psychosocial stimulation by administering a questionnaire to the mothers. All data were collected between November 2021 and March 2022. Now I'd like to share with you some of our results. First, we did a comparison of demographic characteristics at baseline, and we found that generally both groups were quite similar with a few exceptions, like family frequency of meat per month. When we look at our main outcomes, the first thing to note is that we see improvement generally in both arms, which was quite positive. The improvement in subjective well-being were more substantial in the intervention arm, where mothers had lower scores than those in the control at baseline. We saw very little reduction in distress or functional impairment among control mothers. For intervention mothers, they saw relatively greater reductions, but these results were not statistically significant, as we'll see on the next slide. And notably, overall functional impairment did not change much in either arm. We saw less improvement in positive coping in intervention mothers compared to control mothers, contrary to our hypothesis. Alternatively, though at both baseline and follow-up, intervention mothers exhibited more coping than those in the control sites. So these are the actual betas we observed in our regression models that included cluster as a random effect, and in which the control group is the reference here. As you can see, generally we see a greater reduction in distress and functional impairment and greater improvement in subjective well-being. These were not significant once we used the Kenwood-Roger adjustment of standard errors to account for our small number of clusters. Regarding the nutritional status of the children, findings were not as expected. 1/3 of the children were severely acute malnourished, 1/3 were moderately acute malnourished, and 1/3 were non-malnourished. Child development showed better outcomes for the control group, considering that the mean age was similar in both groups. And finally, contrary to our hypothesis, child stimulation, including maternal representations, like with the questions referring to have you felt positively towards your child, for example, they showed overall better results in the control group, and the difference is significant for positive feelings towards their children. So the main takeaway here is that we see potential for integrating psychosocial support activities for improving psychosocial well-being, particularly through reducing distress and improving subjective well-being. But as these results were not significant, we cannot make a definitive statement about the effectiveness of the program in producing change. Notably, results were poor for functioning and positive coping, which encourages us to think more about the specific activities in the intervention and how these important domains might be enhanced in the future. Next step, so far we conducted a parallel implementation research to assess the baby-friendly space from the point of view of service users, their partners, our staff, and stakeholders in refugee camps and host communities. The results will be available later this year. And I'll make a conclusion with a say from a mother who attended our BFS program. She said, "We can take good care of our child by learning these good things from here. If our children are happy, then we're happy also." Thank you for your attention.
Thank you so much, Karine. That was quite a very rich study and very rich presentation. And I'm still kind of thinking through the different aspects and very complex that you had a randomized study, which is, especially in those circumstances, quite different. I'm waiting for questions on this topic. Not yet. So, but I think that I will ask a question myself, if you don't mind, Karine. So once again, highly relevant. You said that the results with regards to the positive coping from side of the mothers was less than you expected. That was different from your hypothesis. Could you elaborate a little bit on why you think that happened? And I'm not sure whether I saw whether it was significant or not.
Yes, thank you, Mirto. This is a very good question, because we actually use the brief cope, which is one of the questionnaire that is used widely and also in this kind of context. So we really expected that we would see some improvement in terms of coping. Actually, our conclusion is that the questionnaire might be not so relevant in that context for those mothers. So this is something that we are trying to explore further. It might also be that only the intervention did not really support the improvement in terms of coping. And we also have the same question regarding the functioning of the mothers and the use of the WHO DAS in this context. So measurement is really something that is coming out as a concern for us in this research, and we are trying to look further and see how we could use either other questionnaires or what actually went wrong with those questionnaires. And we submitted an article on this topic.
Yeah, thank you. Because that's sometimes the concern, because the intervention as such appears to be, it's common sense that it is a positive intervention. And then if your measuring tools don't reflect that, can be quite a hazard. I see a question has come in from the audience. Did you find any mothers with significant mental health problems requiring more specialized support, and were such services available during the study?
Yeah, thank you very much. Yeah, especially in this context, I think it's really important to do a good screening. So we really focus on screening for mothers who have suicidal ideas, and we would refer them to first our psychologist, and if the mother would require more support, we would then refer to another organization in the camp. We did not, as much as I know, our staff did not report mothers with really severe mental disorders, either because then they probably would not come to the program, and they would be referred prior to coming to the program, or just they did not screen and report.
Thank you so much. This is really super interesting, and there's, I'm sure, loads of questions that spring up when you go through it again. But our time is up. And thanks again, Karine, and we're moving on to Ayub. Ayub Mita is our next speaker. Ayub is a pediatrician and a neonatologist at Lille University in France, and he holds a PhD in epidemiology from the University of Paris Descartes, and has a postdoctoral degree in clinical epidemiology from Karolinska Institute in Sweden. He will talk to us about long-term neurodevelopmental effects of skin-to-skin contact. Thanks, Ayub, and the screen.
Thank you for the presentation. So on behalf of all the co-authors, present this study from the EpiPage 2 cohort study, supervised by Véronique Pira, and performed in the Epopee research team. So next slide. Yes, so we know that skin-to-skin is beneficial for the physiological and behavioral stability of preterm infants, and for breastfeeding and bonding between the infants and parents. But less is known about long-term impact. And this study has the objective to evaluate the impact of early skin-to-skin contact on neurodevelopmental outcomes at 5 years and a half among very preterm infants. So this study is based on EPIPAGE-2 cohort study, which is a population-based prospective study of preterm infants in all maternity units in the 25 French regions in 2011. The population was 2,666 survivors at day 8 with gestational age between 24 and 31 weeks. And we performed a propensity score analysis with inverse probability of treatment weighting approach for the statistics. At 5 years and a half, there were 2,561 survivors, and the outcomes were evaluated was cognition and behavioral difficulties. So our results of practice of skin-to-skin contact. In our study population, we had 1,607 infants exposed to skin-to-skin contact and 1,059 infants non-exposed. And we can see in these figures that skin-to-skin contact increased with gestational age from 24 weeks to 31 weeks. From D0 and D7, the first week of life. When we look at the practice of skin-to-skin contact among neonatal units, we can see that there is a huge variation of practice of skin-to-skin contact the first week of life in 2011 in France for the preterm infants from 24 to 31 weeks. And the practice of skin-to-skin contact among neonatal units varies from 15% to 100%. So now, with the propensity score approach, we try to have a balance between exposed and unexposed groups from different characteristics: maternal age, primiparous, the mother born in France, level of education, the socioeconomic status, living in a couple relationship, cause of preterm birth, tocolysis, C-section, anesthesia, multiple birth, gestational age, of course, sex, small for gestational age, the APGAR score, surfactants, CPAP in the first day of life, hemodynamics treatment, mother intent to breastfeed, the volume of patient of neonatal unit and the NEED-CAP neurodevelopmental care training. And based on this, all these characteristics, we, after the propensity score, we all standardized difference between baseline characteristics is less than 10%. So the weighting created a pseudo population with perfect covariance balance based on these characteristics. And at 5 years and a half, we can see that regarding the full-scale intelligence quotient, the means cognition among the exposure infants, there is a trend for increased full-scale intelligence quotient. It's a black square. And when we look at the full scale above -1 standard deviation, there is an increased among exposed infants. And this effect is more, we can see that there is more effect among the population of very preterm, 28-31 weeks, and not in the extreme preterm. We have maybe two hypotheses explaining this difference. First, we have very low, few infants exposed to skin among the extreme preterm infants, and maybe there is still residual confounding measures. So this our hypothesis regarding this difference among the study population. For the outcome of behavioral difficulties, there is no, we couldn't see some effects of skin-to-skin contact regarding this outcome and in all the population. So the strengths of these studies, we were able to evaluate the impact of skin-to-skin contact and long-term neurodevelopmental outcomes from a population based of extremely and very preterm birth with standardized developmental assessments. Of course, we have limitation. We have no information about the duration of skin-to-skin contact and no information on skin-to-skin contact after the first week. And as I already said, despite a good balance between exposed and unexposed groups, residual indication biases or unmeasured confounders due to individual and unique characteristics may be still present. And there is always some intermediate factors. In conclusion, we can say there's a trend towards an association of skin-to-skin the first week of life with cognitive outcome at 5 years and a half among very preterm infants. We can see that the variability of practices among units deserves attention. And next step is evaluation of the dose effect is needed. Thank you for your attention.
Thank you so much, Ayub, for this very, very interesting presentation. I'll quickly jump into the questions. I've got a couple of questions here already. So the first one concerns the difference between skin-to-skin care and kangaroo care. What's the difference between the two? And how did you define skin-to-skin care? For example, in terms of days, hours of the day, and at what time was it initiated?
In this study, the skin-to-skin contact was not defined as a minimum duration of skin-to-skin contact. So it's skin-to-skin contact the first week of life, but we have no information about the duration and the timing, the specific timing, which day the skin-to-skin was performed the first week of life. And the difference between skin-to-skin and kangaroo mother care is that for kangaroo mother care, infants stay more than 18 hours a day with skin-to-skin contact. So it's a longer time of skin-to-skin contact.
There I am again. Thanks for the answer. And what was the rationale to do the evaluation at 5.5 years or 5.5 years of age? Or why did you choose that age? It's good to see a long-term evaluation, by the way.
We know that if the neurodevelopmental outcome at 2 years is limited, and at 5 years and a half, we have more information and more detailed information about long-term neurodevelopmental outcomes, and it was already designed in this in the EpiPage 2 cohort to do this specific and standardized evaluation.
Okay. Thank you. Well, there's a lot of questions, but unfortunately, I just give you one last. What other implications? How can you transfer your findings to to context poor settings, to resource poor settings?
We know that skin-to-skin contact has many beneficial in the short-term outcomes. And this study brings more knowledge for the long-term impact. So it brings more confidence to this practice. There's many beneficial actions for skin-to-skin in the short-term outcomes and for the long-term outcomes, and particularly in this vulnerable population of preterm infants?
Thank you very much. And for those of you whose questions have not been answered, please jump onto the chat and write directly to Ayub, and Ayub will hopefully be able to answer you. So
Yes,
that goes for all the other presentations, of course, as well. Please jump onto the chat and write to the various presenters. Thanks again, Ayub. Well, our next presentation is, and the last for this oral presentation session, is by Sandra Harlas. Sandra is a senior public health officer with UNHCR with more than 20 years experience in humanitarian work. Before UNHCR, she worked with Malteser International and MSF, and her work focuses on access to quality health services in emergency and post-emergency settings. Today, she will talk to us about improvement of care for mothers and newborns in West Africa. Thank you, Sandra, and the stage is yours.
Thank you very much for the opportunity to be here. I'm happy to present today on a number of colleagues whom I listed here across 3 different countries. The project that I want to present today to save maternal and newborn lives was implemented in 3 countries, in Cameroon, Chad, and Niger, all of which are characterized by being resource-poor settings and having prolonged refugee displacement. There are ongoing insecurities in all the countries, and we see, in addition to a long-term refugee crisis, also new refugees coming in, as well as refugees moving across countries, and of course host communities moving across the country due to ongoing insecurities. We had a 3 years funding from the Bill and Melinda Gates Foundation for this project on maternal and newborn healthcare, which built up on an ongoing primary healthcare intervention across the countries, and it targeted 720,000 refugees plus the host communities around in 32 health facilities, including 8 district hospitals. At the onset of the project, we had a mixed method needs assessment looking at health facility capacities, staff capacities, attitudes and skills, but of course also at community level, community perceptions on maternal and newborn health and their priorities. And started from that then to develop tailored action plans for each of the country, but also for facility levels, and developed a detailed monitoring tool in addition to the HIS that we are using, the data of which I'm presenting here today. We then used a master trainer approach. We trained overall 91 people across the 3 years program over a number of different training courses. Focusing on helping babies and mothers survive, family planning, respect for maternity care, but also more other clinical topics like infection prevention and treatment, and also mentoring techniques on how to pass on best knowledge. From there on, the trainers were returned back to their duty stations. There were trainers from Ministry of Health and partner organizations, and implemented low-dose, high-frequency trainings in their respective facilities. So short, targeted session for staff that are repeated over time, rather than ongoing larger training curriculums. We also introduced kangaroo mother care, which wasn't used in any of the facilities before, and did minor rehabilitations to the infrastructure with a main focus on installing 24/7 electricity by solarization and improving waste management, improving equipment and supplies needed for the implementation of maternal and newborn care. And to facilitate the ongoing training, all the facilities were also equipped with a training package like mannequins, the baby natalies and others, so that the nurses and other health staff could actually practice what they are doing. At community level, we trained existing community health workers and former traditional birth attendants by adapting the WHO curriculum, caring for the newborns at home, to the national context in line with Ministry of Health guidelines, and focus there on essential newborn care, hygiene, danger signs, behavior change communication, but also preparedness for birth, how to make emergency preparedness plans, referrals, and others. The trainees were then also equipped with IEC materials, flip charts, but also weight scales to be able to measure newborns. and then conducted structured home visits throughout the pregnancy as part of their routine activities, and then followed up with a structured home visit for the first week of life for the newborns, with at least 3 visits to assess the newborn and the mother, and also make referrals then. In terms of outcomes, we had more than 33,000 deliveries supported throughout the program, and saw notable improvements in clinical skills and availabilities of essential medicines and supplies through a strengthened supply chain. Kangaroo mother care, which was not used before, was used for nearly 100% of all the neonates that had a birth weight of less than 2,000 grams, which was the main focus group for this intervention. The key thing that we saw was a significant reduction in neonatal mortality rates from initially 19 deaths per 1,000 live births down to 12 per 1,000 live births in the end of the intervention. The other thing that we looked at to really see how also clinical skills improved was the case fertility rate over time, and we looked at all newborns that were admitted with complications in the health centers and hospitals, and saw a reduction there in the overall neonatal case fatality rate of almost 50%. And then when we looked specifically at the most vulnerable, those with a low birth weight below 2,000 grams, we saw a reduction of initially from more than 30% down to 12% in the last quarter of the intervention. What we concluded from that was that the combination that we used of having this low dose, high frequency trainings, strengthening health facilities, including supply chains, and working closely with the communities to improve neonatal health did work. We saw this decrease in mortality rates and decrease in case fatality rates. We also looked at the sustainability of the intervention. We had in the funding, there was 2 project cycle fundings with a gap in between of a bit more than 6 months. And we saw that, for example, the low dose, high frequency trainings continued in 2 out of the 3 countries. The 3rd country, a lot of the trainers moved away. So we used the last project period to make some adaptation, including training additional colleagues from the regional health bureaus, their trainings that are colleagues that are coming from the area themselves, but there was a higher likelihood that they would stay on and continue the interventions beyond. We saw also sustainability in terms of supply chains and others that were implemented. What we would want to do is collect also more data to see the longer term effect after the end of the intervention. The primary healthcare project is still ongoing, but there is no additional funding at the moment for these specific activities I described. And what we could not demonstrate due to the small population sample covered was the impact on maternal mortality. We measured that as well, but there was no notable difference. Thank you very much.
Thank you, Sandra. Once again, a really, really, really good presentation, and again, very different, very, very relevant, and huge numbers. I'm looking for questions. No questions have appeared so far. I'm not surprised. There's so much information coming in at the same time that it's not easy to really pick the questions that you have. So one thing that was clearly shown in your presentation was that the approach needs to be multifaceted, and that training plays an absolutely important role. And you mentioned some of the tools that you used. Is there a place where everyone could have access to the toolbox, to the trainings that you used? You said low intensity, high intensity trainings, so that would be really interesting.
Yeah, we have those for our colleagues in the intranet, but happy to share that. If anybody wants to message me, then happy to share that as well bilaterally.
Perfect, thank you. Here's a question. What happened regarding follow-up after the early postnatal period, for example, from 4 weeks onwards? Was there a follow-up by other community services, for example, to monitor growth?
Yeah, so the community health workers were existing before and continued their work, and that was part of the ongoing activities. So they continued basically with their routine activities, including, like, for example, the continuous promotion of breastfeeding, the continuous promotion of immunization, especially follow up on any defaulters, but also advice on general nutrition and later on the transition. Yeah, so that's part of an ongoing activity where we just basically strengthen this specific component around birth to reduce neonatal deaths. But then we have this standard intervention that focus on hygiene and other activities as well, identifying any other danger signs of children for other diseases. So that's part of an ongoing program.
Perfect, yeah. Thank you. One last question. Why did mortality increase in Q3 of 2020 after having reduced in 2019? That's a very detail that I didn't even pick up, but yeah, that's a question from the audience.
Thank you. I was hoping that someone would ask that because I was short of time. We had, due to the insecurities in the area, refugees moved, facilities moved as well, some facilities closed. And we, at that time, included new facilities into the program. So that, like in the beginning, where we had to really work on the quality of care, led in parts to this increase in mortality, which came down at the end again. So it wasn't the same 32 facilities that we had over time. It was this gap that we had in the care, which led to an increase and then came down again. Thanks for asking that question.
Great. Thank you very much. We move on now to our next presenter, and our next presenter is Catherine Hashimoglu. Catherine is a certified child life specialist and recreational therapist. Over the last 13 years, her work focused on psychosocial support and integrated child-friendly approaches to pediatric healthcare. She spent a year with MSF in Sierra Leone to activate and evaluate formal play therapy in the hospital in Kenema. So it's going to be, yeah, go ahead and we'll discuss later. By the way, I forgot one thing to say. After the oral session that finished, you can continue your chats with the presenters, and you can go and try and meet them in the break in the networking lounge. So thanks to all the oral presenters, and this session is officially finished now, and we go on now to Catherine. Catherine, the stage is yours.
Hello, good morning or good afternoon, everyone. I'm Catherine Hashimoglu. Thank you for being here. So I know we just heard a lot about research-based things, and this is a little shift, and this is a P talk, and I'm going to tell you a little bit about my work in Sierra Leone. So 10:30 every morning, the pediatric wards ring out with the words, "Let we go play, play." The people in pink uniforms are greeted with a smile by the kids and parents. The kids are eager to be picked up by the staff in pink, and the parents get up from their bed and walk outside for the most engaging part of the day, play therapy time. In Kenema, Sierra Leone, MSF has a hospital dedicated to children under 6 years, treating malnutrition and complex general pediatrics. In 2021, I had the privilege to arrive on the project to assess and develop a play therapy program. As a child life specialist and recreational therapist who's worked in pediatric hospitals in 5 countries over 13 years, I was ready for the adventure ahead. Within my field of work, we often get comments like, "Wow, you're paid to play," or "You went to school for that?" The answer is yes. I hold 2 bachelor's and a master's. My specialty is helping children and families navigate stressful situations, understanding the way that young minds and bodies interpret their life experiences, and helping them process and cope with difficult events. The goal of my work in Sierra Leone was to ease distress in children and families, support positive experiences in the healthcare setting, improve the social and emotional well-being of children, and strengthen child-caregiver bonds. I'm not a magician. I can't make every bad situation good. Being in the hospital is difficult, yet there's a simple but powerful anecdote that research and practice shows us have a significant outcome on healthcare, and it's play. Maria Montessori told us play is the work of children. Albert Einstein said play is the highest form of research. And Plato speculated you can discover more about a person in an hour of play than you can in a year of conversation. So arguably, since about 400 BC, adults have emphasized that play has many essential functions for children. Integrating play into the healthcare setting aligns with respecting the human rights of children and helping children heal from trauma and illness. Arriving in Sierra Leone, I was met with both enthusiasm and uncertainty. Most people did not know what play therapy was or why it was being integrated into our care model. The national staff warned me to be careful, as those who play with children may be perceived as being a witch and gaining the favors of children to cast a curse on them. The program started with an assessment of the existing space. The hospital was bare, white metal walls, white metal beds, gray floors. Children slept for large portions of the day, not because they needed that much rest, but because they were bored. A previous attempt to do some mural painting resulted in images of Ebola, poor toileting practices, disease, and displacement, all real and distressing realities of Sierra Leone, but not the most child-friendly. Kenema is a lush region. The hospital settled in the valley of red soil and rolling green mountains. The local clothing is made of colorful Lapa material. One of the primary goals was to create a more child-friendly space, and the natural landscape and culture of the clothing was inspiring. Stimulation is an essential part of recovery and malnutrition, and visual stimulation can engage children from various points of recovery, from those on bed rest who need stimulation for cognition to more recovered patients who might need some motivation for ambulation. We painted the family areas. We integrated some simple playground equipment. We designed a playroom, and we added color and activity gyms to all of the wards. Introducing toys in the hospital was a fun and unique experience. We started simple, recycling materials found on the project. Formula cans turned into drums and towers, medicine bottles into musical shakers. As I navigated my way through the procurement process, my biggest challenge of the project, we slowly integrated more toys and taught children how to play. While play is an essential and natural condition of the child, in harsh environments where able bodies help around the household from young ages, play may not be nurtured. Giving children access to play is one of the first steps to integrating child-friendly practices into humanitarian interventions. And the best part is, there is no wrong way to play. The mental health team spent countless hours in trainings and practice playing to understand how to create optimal play environments that empower infants and children to try new skills like reaching, rolling, sitting, or walking, building curiosity, increasing confidence, expressing their emotions, and strengthening their bond with their caregivers. The amazing team embraced it all and transformed perspectives on the value of play and made this play therapy program and continue to do so to this day. Now, in healthcare outcomes, in healthcare settings, we like outcomes. So I want to share a story with you. And I call this the case for ambulation. And this is me lying on the ground. A 4-year-old patient was admitted to the pediatric ward with weakness and tiredness. The diagnosis is complex malaria and the child's treated. The medical team can't discharge the patient though, because the child refuses to walk. And the team's concerned there's another problem, despite the x-ray being clean. The play therapy team is consulted because the child's bored while waiting in the hospital. We carry the child to the outdoor play space. Here there is a variety of toys and other children playing. The child initially sits and does not show interest in the activity. That's fine, we leave him be. Slowly he gains interest in other children and toys and starts reaching for some items. Fast forward about 20 minutes and the child's kicking a football around with another patient, unprompted. When the play session ends, the child walks back to the ward with a big smile on his face. And the medical team asks, how'd you get him to walk? And how'd you get him to smile? We haven't seen him smile this whole admission. In healthcare environments where often the cries and protests of children screaming about needles and painful procedures are ignored, and children are not informed about care being provided to their bodies, the answer is we gave him a safe space where we honored his emotional state. We gave him freedom of choice, encouragement, and motivation. And all of that was done through the lens of play. Play is a gateway to more than just fun. Therapeutic play allows children to communicate their experiences, safely process stressful events, learn and practice coping skills, explore the environment around them, and regulate their emotional state in which they can better cooperate, heal, and thrive. As we think about what healthcare looks like for children, we must meet children in a space that allows them to be participants in their care, not just recipients. To get there, each provider must ask how they can support a child-friendly healthcare agenda, from building infant gyms to designing playground equipment, collecting recycled materials, assisting with ward modification to meet infection prevention and control standards, to approaching carers with a smile and compassion. Each person has the ability to do their job and say, "Let we go play, play." Thank you so much. And if you have any questions, I'll be in conversations and coffee.
Thank you so much, Catherine. That was absolutely fantastic and so important. We keep forgetting that sometimes we forget that we don't treat patients, we treat people, we treat children. So if you want to talk to Catherine, and that goes the same goes for Johanna, they're in conversations in the break over coffee. If you scroll down on your screen, you will see 2 tags. And if you click on those, you will be able to join each of those 2 presenters. So thank you again, Catherine. And now we move directly on to Johanna. Well, Johanna will show us a newborn care training video. Johanna is an Australian pediatrician based in France. She holds a master's in international public health and has extensive experience in pediatric education. She has worked with MSF for more than 10 years in the field, as well as in various headquarter positions. Johanna has made a substantial contribution to the development of guidelines and trainings throughout MSF today. Thanks, Johanna, and the stage is yours. And as I said, the questions you can ask Johanna in conversations over coffee.
Thank you, Myrto. I'm really happy to be here today and excited to announce the recent release of some MSF newborn care learning resources. So we've created a hybrid learning package that includes online learning, remote virtual classes, and bedside teaching activities. I'd like to send a particular shout out to our colleagues in South Sudan, where we recently piloted the training program. And a big hello to our colleagues in Dakar, and a big thank you to the Dakar unit, where we ran some educational activities, teaching activities last week, including piloting some of these modules in French in a face-to-face environment. Now, I'd like to share with you a brief video of the training in action, and I'll be available with my colleague Marie Clarice during the conversations in coffee to discuss further. Thanks.
Hello, and welcome to the MSF Newborn Care Learning Package. The newborn period is the riskiest time of a child's life, with neonatal mortality accounting for almost half of all deaths in children. Nearly all of these deaths occur in countries with limited resources, and almost all are preventable. Most newborns would survive with simple, inexpensive, evidence-based interventions. But newborn care requires teamwork, consistency, and meticulous monitoring to be effective. In addition, newborn training requires an approach that is distinct from general paediatric care. Endorsed by the MSF Intersectional Paediatric Working Group and Nursing Care Working Groups, the MSF Newborn Care Learning Package was developed to address this need. This hybrid learning program consists of 3 phases. 1, self-paced e-learning modules on Tembo. 2, profession-specific virtual classes led by a facilitator. And 3, clinical activities and bedside teaching. The Newborn Care Learning Hub on Tembo gives learners access to several digital learning modules related to the care of newborns. These modules are designed for medical, nursing and midwifery staff who care for newborns in a hospital setting. There are currently 11 modules available, with further modules under development. Each module is designed to take 1 hour to complete and is composed of a theory section, a series of case studies with multiple choice questions, and a quiz at the end of each module. After completing the module and the accompanying quiz, learners receive the Tembo Completion Badge. The virtual classroom component is the second phase of the training, following on from the self-paced online learning modules. These tutor-led sessions are profession-specific, designed to take the learner through issues relevant to their field of practice. For each learning module available on Tembo, there is a corresponding virtual class. Learners are eligible to participate in the sessions once they have completed the online learning and achieved the module badge. Each class consists of 2 hours teaching with an instructor, as well as 2 hours of pre-reading and preparation. This time should be scheduled into the learners' working hours. Learning exercises should be completed prior to attending the class to encourage active participation and participant interaction. Learners receive a learner workbook with all the clinical case studies and accompanying questions, as well as relevant clinical guidelines. In order to consolidate the learners' newly acquired knowledge and skills in newborn care, we recommend a series of clinical teaching activities at the bedside. This clinical teaching can be performed by paediatricians, field-based doctors or nurses, or nursing care supervisors. Flying trainers and mobile implementation officers may also provide such educational support during field visits. For each of the learning modules, a series of recommended clinical teaching activities is outlined. The teacher or clinical supervisor should observe the learner performing the activity, allowing space for discussion and questions. Structured feedback should be provided and any areas of improvement discussed. The corresponding job aid is designed to be used as a quick reference during daily clinical activities and can be referenced during these clinical activities as a reminder of the most important aspects to cover. All learning is based on recommendations in the recently released neonatal care package, including the MSF Clinical and Therapeutic Guidelines, the Neonatal Nursing Care Guidelines, and the Neonatal Injectable Medication Handbook. Throughout the course, we promote a family-centred approach that puts mother and baby at the centre of all cares. With sustained commitment, effort and training, we can reduce neonatal mortality and make sure that all newborns are given the chance to survive and thrive.
Thank you. Thanks, Johanna. Just as the last presentation, so important, so extremely important. As I said as well in the beginning, training is important, and training that is relevant and is not just giving someone a textbook. Just a quick question with regards to the Tembo that you mentioned, because I know that we have people watching that are from outside of MSF. Are these materials available from people from outside, or is it just MSF internal? Thank you.
No, anyone can join and do the online learning modules on Tembo. The virtual class component, we've just piloted and we're still reflecting on how we make that available. But the online learning component is available by joining through your personal email account.
Okay, thank you very much. If you want more about this, as I said, sorry, in the conversations over break, join Johanna, join Catherine by scrolling down to the respective buttons. And if you don't have time, just send them an email or chat with them over the chat, because I think it's extremely relevant to think outside of the mere medical gesture that we do at the bedside, but how to do it and how to do more for the children. I was very impressed, Catherine, by all the colors in your presentation, and playing for children is so important, and we've forgotten that for decades in MSF. So thanks again. Now, without any further ado, we will move on to the speed poster session. We received more than 30 posters, and out of those 30 posters, 5 posters were selected for the speed poster session as a kind of a teaser. And it's not necessarily because they were the best ones, although they're very good, but it is because they were also received ahead of time so that we could facilitate the speed poster session. Each presentation will be 1 minute, and if you want to speak to the presenters and see the other posters, please go to the poster hall in the break. So I think we can start with the poster session now.
Bonjour, je suis le docteur Jafet Nguina depuis la République démocratique du Congo. À l'hôpital général de référence à Kisantu, le salmonelle anontifie est responsable pour 3 de 4 bactéries chez les enfants de moins de 5 ans. Pendant les études prospectives que nous avons menées, nous avons observé que 10 de 304 enfants suivis avec bactérémie à salmonella nontifi, avaient développé des complications ostéo-articulaires comme dactylite, ostéomyélite et arthrite. Ces complications étaient négligées dans le passé, mais ont des répercussions importantes pour la prise en charge. Il faut exclure la drépanocytose, drainer et mettre en culture le pus et adapter la durée d'antibiothérapie. Il est alors essentiel de veiller sur ces complications pour chaque enfant avec bactérémie à salmonella non typhée. Je vous remercie.
For 5, 10, 20 years ago, I never could imagine how challenging the management of neonatal hypothermia in limited resources could be sorted out. That's why, to tackle this issue, we conducted an operational pilot to test the safety and the effectiveness of a warming blanket called Wamilu. The pilot included 40 newborns in Kusisa Hospital during the period from January to May 2021. And the result from this pilot reaffirmed hypothermia as the first risk factor for mortality in neonatology. And so far, it confirmed Wamilu blanket to be significantly a device that could reduce the number of hypothermia events. And so far, to be safe, a safe warming device in electricity constrained setting. Thank you.
Hello everyone, my name is Gildas Redible. I work at INSEM in Toulouse. Thank you for giving me the opportunity to present my work about the use of pulse oximeter into the integrated management of childhood illness IMCI. This research is implemented at primary health center level in 4 West African countries, and in this context, under 5 years old mortality rate is very high, and it is urgent to better diagnose children, especially the hypoxemic children, to address an appropriate care. This work is entitled Integrating Pulse Oximeter into IMCI consultation to improve health care of under 5 in primary health center in West African country. So I invite you to visit my poster on the virtual platform and ask many questions.
Hello everyone, I'm Claire Bossard from Epicentre. I'm delighted to quickly introduce you to the poster on a study called STIMNUT, which stands for Psychosocial Stimulation in Nutrition. The study is conducted in Koutiala in Mali since July this year, and it's still ongoing. Therefore, you will only find preliminary results in the poster, and you will have to wait until the next conference to discover the final ones. The aim of our study is to assess the feasibility and acceptability of integrating an adapted version of a psychosocial stimulation intervention developed by the NGO Action Against Hunger into the Koutiala Therapeutic Feeding Program for children aged 6 to 23 months with severe acute malnutrition. The expected impact of this study is the development of a framework that may enable the intervention to be adapted and reproduced in other contexts. So please come and have a look. Thank you.
Hi, I am Hedwig de Koning for the Momentum team in South Sudan, where we conduct a study on the management of small and nutritionally at-risk infants and their mothers, called the MAMI care pathway. The innovation is that vulnerability factors of both the infant and mother, including maternal mental health, detect risk early, and that moderate risk pairs are monitored in primary care until the infant reaches 6 months of age. Together with the MOH and key partners, we first have adapted the care pathway to the national health system, and next have started to explore the effect on infant growth and development, and the feasibility and acceptability of integrating it into IMNCI and community health services. We show you the risk criteria and the integrated care pathway activities on the poster, but next year we hope to enchant you with our findings. Thank you.
I have to say, on a very personal note, I'm very happy to have seen this STEAMNIT poster, because 3 years ago, before I left MSF, I was involved in the preliminary discussions about that study. And at that time, it was not that clear that it was ever going to see the light of day. So very happy. Anyway, so we are done with this first part of the day. There's quite a few questions just coming in on the Q&A forum on the oral presentations, but unfortunately we do not have time to present those questions here. But as I said, please contact the presenters via the chat and or see them, try to meet them in the networking lounge. And as I said, for Catherine and for Johanna, please go and meet them by scrolling down in the specific forums in the conversations over coffee. So now we have a 22-minute break, to be clear. We're going to see each other at 10 minutes to the hour and to continue with the second part of this morning. So please don't forget to come back and at 10 minutes to the hour. And of course, you can go to the booths and go to the poster hall. Don't forget to use all those interactive functions. It's quite a fantastic platform. Okay, see you later. Hello, everyone, and welcome back. I hope you all had a good break and benefited from all the different features on our platform. Welcome back again. This session on zero separation and family-centered care will be chaired by Sophie Janet. Sophie is a pediatrician specialized in newborn care. She holds a master's degree in international health and tropical medicine from Oxford University. She has worked with various organizations across Africa, Asia, and America, and is currently working as pediatric advisor with MSF based in Dakar in Senegal. Thanks, Sophie. Look forward to listening to the session on family-centered care and zero separation.
Thank you, Myrto. I'm really excited to be here on this session on family-centered care and zero separation. Person and family-centered care is one of MSF priorities to provide respectful, holistic, and quality care to the population we serve. This approach leads to better health outcomes, improved experience of care, empowers family, and wiser allocation of resources. However, its implementation in newborn care is hampered by the current health system status quo, which provides silo care for mother and their babies and systematically separate them directly after birth when requiring medicalized treatment, despite the proven benefits of keeping them together. The current health system paradigm underestimates the value and importance of the mother and baby dyad. And today, we're challenging this practice. During the session, under the umbrella of family-centered care, we will introduce the concept of zero separation with a short video. After, the team in Tanzania, who participated on the multi-center randomized control trial on immediate kangaroo mother care led by WHO, will present the findings of the study, followed by the experience of a mother and a nurse who participated in it. Next, we will have Dr. Barbara Moreno Sanz from Spain, who will share her experience on implementing and scaling up family integrated care in the neonatal intensive care unit of her hospital. And as a final speaker, we have the privilege to hear a mother from South Africa and the founder of a parent association for premature babies, who will share her experience and perspective as a mother. After the presentation, we will have a multidisciplinary panel discussion to reflect on the opportunities and challenges to achieve family-centered care and zero separation in MSF. As a reminder, you will be able to ask your questions anytime, and like the question of other participants. In view of the limited time, only selected questions will be answered during the panel discussion. But remember, you will be able to ask unanswered questions to the panelists over coffee at the end of the day. I really hope this session will inspire you and challenge us the way we care for mother and babies. Now, let's start the session with an introductory video that will take us through what exactly does it mean zero separation in MSF. Thank you.
What is zero separation? Zero separation means creating the best possible conditions for mother and babies to receive coupled care starting from birth. It is a concept that lies within the people or family-centered care framework, the needs-based approach, and respectful maternity care. It has different dimensions: proximity, physical and emotional, and integration of mother and baby care, which means providing care and responding to the dyad's needs at any given opportunity. It can be applicable at all levels of care and in any setting. A health system that embraces the concept of zero separation is designed in a way that reduces unnecessary separation of the mother and her baby, removing barriers that hamper proximity and integration of care across the continuum of care. During the mother-baby health journey, there are many opportunities to promote and strengthen the couple. For example, at birth, the mother and her baby should have the possibility to be together, starting breastfeeding and skin-to-skin as soon as possible. Neonatal units should be organized in a way that facilitates a comfortable and appropriate space for mother or other family members to be with the sick newborns and participate in their care. When providing care in the hospital, primary or community level, we could respond to the medical and emotional needs of the couple at the same opportunity. For example, when doing a newborn consultation, health staff could ask the mother on her nutrition, mental, and medical health needs, and vice versa. Zero separation is a call for action for all health workers to rethink the care they provide to mothers and babies. It can be gradually integrated into MSF operation and might look different in each setting. Why should a zero separation approach be adopted in MSF? During the early 20th century, when the birthing practice moved into hospitals, war routines separated newborns from the mothers and other family members directly after birth in most high and middle income countries. Health systems were planned around the care provided, prioritizing practical organization aspects above patients' needs. For instance, it was easier for doctors to take care of patients without family around and easier for a specialized team to work in silos. Since then, separated medical wards and siloed care for mother and babies became the norm, even in humanitarian settings. This approach to healthcare underestimates the value and importance of the mother and baby dyad. Today, we're challenging these inherited practices.
What are the benefits of zero separation? Ultimately, zero separation reduces mortality and morbidity. There is solid evidence to show that even newborns that are sick and unstable can have better quality of care if they have skin-to-skin contact with their mother from birth. It reduces complications such as infections, hypoglycemia, and hypothermia. Additionally, breastfeeding increases and the bond between the mother and the child is reinforced, reducing maternal stress.
It ensures that mothers are provided with respectful maternity care by highlighting that it is the mother's choice whether to be close to her baby or not, and her choice shouldn't be limited by how the health system is organized.
Partnership between the health staff and the caregivers is enhanced in taking care of the baby and its needs, with the added value of increasing the quality of care and reducing the burden of staff health.
Zero separation is an opportunity to carry out patient-centered care for mothers and their baby in our project. We can start by reflecting on the barrier that may come up in the project we work on to achieve zero separation. How can they be overcome from multidisciplinary perspective, including not only health staff, means nurses, doctors, midwife, also other profile like logistician, admin, HR, health promotion, mothers, families, and community, spread the word and start the change.
Contact your pediatric, sexual and reproductive health and nursing advisor for more information.
Has sparked your interest and you want to hear more. It is my pleasure to present Dr. Naomi Amond, pediatrician at the Muhimbili National University Hospital in Tanzania, who will share their experience on their participation in the immediate kangaroo mother care study, followed by a mother and a nurse testimony. Over to you, Dr. Naomi.
Hello, everyone. Thank you for listening. Now, everyone is
We cannot hear you, Dr. Naomi. Are you there?
Yes, I'm there. I just setting my shed.
We're just arranging a few things.
Yes. Okay. So, hello, I'm Dr. Naomi Mwamanenge. I'll be presenting immediate kangaroo mother care study that we did, Tanzania being one of the sites. Hello, everyone. I'm Dr. Naomi Mwamanenge. I'm a pediatrician. Currently, I'm doing Masters of Clinical Science in Neonatology at Muhimbili University of Health and Allied Sciences. Today, we're going to talk about immediate kangaroo mother care, a study that was done among 5 countries by WHO, and Tanzania being one of the sites. So, introduction. WHO defines kangaroo mother care as the care given to preterm and low birth weight infants, where the mother keeps the baby skin to skin on her chest between her breasts continuously until the baby no longer wants to stay in that position and exclusively breastfeeds the baby. Immediate kangaroo mother care is defined as a practice where KMC is initiated immediately after birth. So between the years 2018 and 2020, the World Health Organization conducted a multi-country randomized trial on kangaroo mother care, shortly named the Immediate Kangaroo Mother Care Study. The aim of the trial was to evaluate the impact of continuous mother care initiated immediately after birth, compared to kangaroo mother care that was initiated after the child was stabilized on the survival of newborn with birth weight from 1.0 kgs to less than 1.8 kgs, born in low resource settings. So the trial was undertaken in 5 tertiary level hospitals, Ghana, India, Malawi, Nigeria, and Tanzania. A total of 3,211 infants and their mothers from all centers were randomly allocated. 1,609 were in the intervention group, while 1,602 were in the control group. For babies in the intervention group, skin-to-skin contact was initiated immediately after birth by mothers or surrogate, and babies who were in the control group had brief session of skin-to-skin contact when the mother visited the baby for feeding. So the median daily duration of skin-to-skin contacts was 16.9 hours in the intervention and 1.5 hours in the control group. Neonatal death occurred among 12% in the intervention group, while in the control group, it was 15.7%. The trial proved that immediate kangaroo mother care resulted in a significant reduction in the neonatal mortality. So this is the model of the immediate kangaroo mother care, the wards where we conducted our studies, and you can see the mothers with their infants skin to skin and doing immediate kangaroo mother care. So why immediate kangaroo mother care? Globally, about 15% of newborns are born with low birth weight as a result of preterm birth or intrauterine growth restriction or both. So up to 70% of the neonatal death occurs in these newborn. These cause of death of low birth weights included respiratory and brain immaturity, hypothermia, hypoglycemia, and infection. Studies have proven kangaroo mother care to be one of the effective interventions for improving survival of the low birth weight infants. The immediate kangaroo mother care trial showed that when kangaroo mother care is initiated earlier, it becomes more beneficial. So what are the benefits of the kangaroo mother care? So we know that there are several benefits of kangaroo mother care, including can help in thermoregulation of the baby, they help in regulating of the heartbeat of the baby, they help in reducing the risk of infections, they create they lower the stress to both mother and baby. They promote breastfeeding and breast milk production. They improve bonding between the mother and the baby, and they increase overall survival of the baby. So, but we had challenges that we faced while we were doing the immediate kangaroo mother care. Some of the challenges that we highlighted were including identification, availability, and preparedness of the potential surrogates in scenarios where the mother couldn't provide kangaroo mother care within 72 hours after delivery. Also, we had shortages of space. The immediate kangaroo mother care ward had only 8 beds, and enrollment has to be stopped when no beds were available. Also, some babies and their mothers overstayed in the immediate kangaroo mother ward due to shortages of beds in the stable kangaroo mother wards. It was a new practice that was not well known to the untrained hospital staff. This led to delays in the initiation of kangaroo mother care, and routine hospital practices such as systems of admissions also led to delays in its initiation of kangaroo mother care. So immediate kangaroo mother care and zero separation. As you know, we're aiming at zero separation. So it provided a golden chance of no separation to the newborn with low birth weight and its mother, even when the baby is recovering from possible complications of early life. If routine practice, immediate kangaroo mother care may play a major role in reducing neonatal mortality, especially in developing countries, since it is efficient and cost-friendly. Immediate kangaroo mother care should be made one of the key components of zero separation package. If well practiced, immediate kangaroo mother care plays a big role in reducing the burden of hospital, especially in developing countries, by reducing the duration of hospital stay, need for prolonged use of antibiotics and intravenous fluids, breast milk supplementations, risk for postpartum depression and anxiety. So what are the lessons that we learned while we were doing this, while we were conducting this study? So when hospitals are provided with trained staff and are equipped, then kangaroo mother care can be initiated immediately after birth. Educating the mothers about immediate kangaroo mother care and reassurance are very crucial for the practice to be successful. Mothers can ease the burden of hospital staff by constant watching over the sick newborn and reporting unusual events. So what is our way forward? So tertiary hospitals with high rate of premature deliveries should be empowered to have immediate kangaroo mother care wards. Nurses should be trained on immediate kangaroo mother care, so it can be practiced routinely for babies who are born stable. There should be a global campaign to raise awareness about immediately kangaroo mother care, as many healthcare providers are unaware of it. Thank you very much for listening.
Misozi Mohamed tokea Mbagala na miaka 29. Nilifungua tarehe 2 mwezi wa 7 2018. Hasa mapacha watoto walikuwa hawajatimia miezi yao. Mmoja alikuwa na kilo 1 na gramu 25, mmoja na kilo 1 na gramu 5. Nilipojifungua tu nikapelekwa KMC, ambayo ni wodi ambayo watoto ambao hawajatimia. Shida ni kwamba mmoja alikuwa hawezi kupumua vizuri, kwa hiyo nilipata ile oxygen ikamsaidia, huku nikaendelea kukaa nao mwenyewe kifuani. Wote wawili niliweka. Kwanza nilikuwa na hofu, ila nashukuru manesi walionielekeza nikaweza kumsaidia mwanangu, nikaelekezwa jinsi kumweka kifuani na kumpa hilo joto. Kama kuna tatizo linatokea, unamuita nesi anakusaidia pale. Nashukuru huduma nilipata vizuri. Kwa mimi binafsi nilifurahi kwa sababu nilikuwa nahitaji nijue hatua moja hadi nyingine mwanangu jinsi anavyoendelea. Nikajisikia faraja kwa sababu sikuwa peke yangu, tulikuwa kama grupu la watu wengine. Kwa hiyo tulikuwa tunafurahi. Changamoto zipo kama hivyo, kuna ule uzoefu, lakini kama ndio ushaelekezwa jinsi ya kuwakea watoto, unaangalia kama hivyo, akikaa vibaya naomba weke vizuri. Basi ni changamoto tu ndogo ndogo. Kwa ushauri wangu nawaambia kina mama ndike mioyo, kwa sababu unakuta mwingine anakata tamaa, mwanangu hajatimia, basi sidhani kama yuko sawa, ila wauguzi ukikutana nao hana shida, wanakusaidia na mtoto wako anakuwa tu vizuri. Wauguzi wa KMC kwamba juhudi zile walizokuwa natuwekea wagonjwa endelee. Kwa ushauri wangu naomba zoezi hili liendelee kwa sababu inasaidia na imeshasaidia mpaka sasa. Watoto wana miaka 4 hawana tatizo.
Kwa majina naitwa Bonifasi Mwagara. Nilikuwa ninafanya kazi hapa Muhimbili kama research assistant katika wodi ya KMC kwa muda wa miaka 2. Taaluma yangu ni nesi muuguzi midwife, na majukumu ambayo nilikuwa nayo katika wodi ya KMC ilikuwa ni kuhakikisha mama anapata huduma, mama pamoja na mtoto ambazo ni stahiki, lakini pia kuhakikisha zile data ambazo zinahusika na masuala ya KMC zipo vizuri. Pia huduma ambazo tulikuwa tunawapa watoto ilikuwa ni kuhakikisha kwamba mama anamweka mtoto skin to skin kwa muda wote ambao anakuwa yupo wodini, na ikitokea ameacha kwa muda mfupi na kwenda kuona na daktari, hapo ndo alikuwa anaweza kumwacha mtoto. Lakini tulikuwa tunahakikisha masaa mengi ilikuwa ni kumweka mtoto skin to skin. Jambo lingine, unamsaidia mama kuweza kumnyonyesha mtoto kwa wakati au kumpa mtoto maziwa. Kwa mimi, kwa utendaji kazi wangu kubadilika, naweza kusema ulibadilika kwa sababu kwa mara ya kwanza tulikuwa tunaijua KMC, lakini kwenye utafiti tukaijua IKMC. Kwa hiyo ni kitu kiliongezeka pale. Utendaji kazi ulibadilika kwa kiwango kikubwa kwa sababu nilikuwa sijui jinsi ya kutumia mashine zingine. Baadhi ya mashine kama CPAP niliweza kutumia nikiwa IKMC. Kwa upande wangu haikuathiri, IKMC haikuathiri chochote, zaidi iliboresha kwa sababu mama alikuwa na uwezo wa kukaa na mtoto muda wote skin to skin, na huduma zingine zikaendelea. Moto zilikuwa ni za mara chache. Kwa mfano, kuna mama alikuwa maybe anaenda kujifungua kwa operation, na mama wengine walikuwa ni wagonjwa. Pia tuliweza kuitatua kwa kutafuta surrogate ambaye anaweza kukaa na mtoto kwa muda ule ambao mama atakuwa bado yupo recovery. Changamoto kubwa ilikuwa ni kupata surrogate. Faida kubwa, watoto wengi kupitia hiyo huduma, watoto wengi walikuwa wakipona. Pia tulihamasisha ule uhusiano wa mama na mtoto. Na kwa mama, faida kubwa ambayo alipata elimu kuhusiana na jinsi ya kuishi na ule mtoto, kwa sababu bado alikuwa ni mdogo. Wengine walikuwa wakiogopa. Sisi watoa huduma ya afya tujitahidi kuwapa elimu nzuri wa mama, jinsi gani ya kuwahudumia watoto, kuwapa elimu juu ya usafi kwa ujumla pindi wanapokuwa wapo na wale watoto. Nashauri pia wawe wanatoa elimu zaidi kuhusiana na KMC. Maoni ambayo niliyapata kuhusiana na huduma ya KMC kwa mama, asilimia kubwa mama wengi walikuwa wanaifurahia huduma na kuwapongeza watoa huduma, kwa sababu ilisababisha kwamba watoto wengi walipona.
Naweza kuwashauri wauguzi wenzangu, hasa wale wanaofanyia wodi za KMC, kufanya kazi kwa bidii na kujitolea kusikiliza changamoto za kina mama kwa ukaribu zaidi na kuzitatua. Napenda pia kushauri zile hospitali kubwa ziwezeshwe ili ziweze kutoa huduma hii ya KMC ili kuokoa maisha ya watoto.
Thank you, Naomi, Magdala, and Wendy, for sharing this important study and your valuable experience. It is impressive to see how there was a 25% reduction on neonatal mortality at 28 days in the intervention group. No wonder why these results have shaped the new WHO recommendations for caring for low birth weight babies. The results of this study indicate the need for a global paradigm shift in the care for low birth weight babies. To allow immediate KMC, we need to ensure that mother and her babies are kept together since birth. For those who want to read all the details on the study and the new WHO recommendations for low birth weight babies, please find them in the resource library. I would now want to invite Dr. Barbara Moreno-Sanz, pediatrician from La Paz University Hospital in Spain, who will share her experience on the implementation and scale up of family integrated care in the neonatal intensive care unit at her hospital. Over to you, Barbara.
Good morning, I'm Barbara Moreno Sanz. I'm a neonatologist from La Paz University Hospital in Madrid, Spain. And today I would like to share with all of you my experience with the Family Integrated Care Model, or as we commonly call FICARE, and the results we have obtained so far. We have published this paper in which we tell our experience from when we formed the working group until we started the pilot study. I will comment step by step how we did it. The burden of adverse short and long-term outcomes in the newborn who suffers prolonged neonatal intensive care unit stay is at least partially related to parental stress and family dysfunction. New healthcare models that focus on the family, the so-called family-centered care policies, have been proposed to overcome these issues. Family integrated care integrates parents in the direct care of their baby as part of the healthcare team and has been shown to have a positive impact on the infant's short-term clinical outcomes, parental empowerment, as well as decreases anxiety, depression, and post-traumatic stress on the families. Up to date, the reports of FICARE model implementation are almost limited to stable preterm infants admitted to NICU. We aim to adapt the 4 pillars of the FICARE model as described by professionals from Mount Sinai Hospital in Toronto to our level 3C neonatal intensive care unit. Our purpose was to scale up the parent training curricula, making it suitable to surgical and non-surgical, non-stable, high-risk infants. This presentation focuses on the FICARE implementation strategy used in our clinical setting and the effort used for its development. 2 potential limitations for the implementation of FICARE were considered: the absence of single family room and the COVID-19 pandemic. That was scheduled as Step 1, co-creation process to define the FICARE implementation protocol and to develop the training program and teaching material. Step 2, which consisted on the internal dissemination strategy among neonatal intensive care unit staff. And finally, Step 3, when we planned to start piloting the FICARE model at our setting to assess its feasibility and to refine procedures before it will be open to all admission once the architectural renovations is finished. Between March 2017 to April 2018, a co-creation process was undertaken by the FICARE implementation team that include nurse assistant, doctors, as well as psychologists and social workers from patient association and veteran parents. An analysis of current procedures for critical care to identify needs, wishes, and requirements was carried out. As a result, the following entry and exclusion criteria to run the FICARE pilot inside were defined, basically covering all patient family dyads for whom more than 3 weeks of admission were expected and have no intellectual or language barriers to understand, providing a decision to provide full leave support was taken, and the family expressed their wish to be included and had signed the informed consent form. A critical point was to attend teaching session for what willingness to spend at least 6 hours per day in NICU was mandatory. A teaching manual was developed that covers both professional and parental curricula with several modules that were identified as the minimum training content to be delivered. Regarding family caregivers, taking part in baby care was categorized into intervention levels, basic and advanced, that cover specific tasks training for infants who require even more specialist care. A teacher education system was established. The FICARE coordinator defined the mentor-assigned training groups and the calendar. Face-to-face meeting took place along 2 months, reaching 90% of the NICU staff to become facilitators of FICARE. From July 2018 to December 2020, a total of 76 parents and 91 infants were included in the FICARE program. The most frequent neonatal diagnoses of participating infants were prematurity in 75% of cases, followed by congenital heart defects in 14% and different genetic syndromes or congenital defects in less than 5% of the cases, including 2 infants with congenital diaphragmatic hernia assisted by extracorporeal oxygenation membrane. Median infant's age at enrollment was 1 week, without differences between preterm and other complex neonatal conditions. About the impact of COVID-19 pandemic, there were no differences in the number of infant diets included in the program per month. In the pre-pandemic period, fathers and mothers spent a median of 7 and 10 hours respectively with their children, and in the post-pandemic period, 5 and 6 hours. Mothers spend more time in NICU than fathers, irrespective of the period that was observed. The family training process relied on workshops and individualized learning by task through face-to-face sessions at cut size, following an individualized teaching plan adjusted to the baby's clinical condition and the wishes of the parents. In 70% of the scheduled tasks, certification was accomplished within the expected time or earlier. 6 out of 20 blocks of tasks, however, took more time than expected for full accreditation. The feedback on the individual progress reported by either parents or professionals involved in training was used to adjust and refine the work plan. Barriers more frequently identified were nursing staff reluctant to fully adhere the model due to insecurity about parents or own knowledge, transfer of parental knowledge in changing nursing shift, and transition from neonatal intensive care unit to intermediate care halted parental training. Different actions such as grouping patients in the same ward, a standardized template to address the individual teaching plan, continuous education of neonatal intensive care unit staff, and weekly FICARE rounds by responsible person to ascertain individual progress were undertaken to foster FICARE implementation. The satisfaction questionnaire about the FICARE program for families revealed learning material, workshops, and outside teaching sessions as essential for their training. Parents reveal decreased stress and anxiety and will accept to enter the FICARE program again through testimonies like, "My answer is yes, 1,000 times yes. This program was determined to learn how to deliver the care that my baby needs. The program allows us to behave as real parents and not mere observation of our baby's life. As conclusion, FICAR implementation in all levels of care in NICU is feasible even when facing two important adverse conditions. One, the absence of single family room facilities, and two, the strict visitor restrictive policies during the COVID-19 pandemic. Even in the case of thorough planning, continuous follow-up and eventual adjustment according to the current condition to solve difficulties raised by both professionals and families are key elements for the project's success. And now what happened? The Rising Family is a project funded by European Commission through a Horizon 2020 grant. The first objective is to scale up and adapt the FICAR model by including a wider geographical and sociocultural diversity at a total of 7 clinical sites at Zambia, Romania, Turkey, United Kingdom, Netherlands, and Spain. We all have to be able to implement this model in the hospital of the consortium, taking into account the sociocultural differences of each country. The project has been running for a year in which we have known each of the hospital and we have created all the necessary material to train healthcare professionals and the families. Now we will continue working hard in the next months to ensure that these countries can also benefit from the FICAR model. With this project, I want to show that this is possible in each hospital. It only takes people interested and involved in changing care for newborn and their families. Thank you for your attention.
Some structural and spatial limitation and the restricted family visit policy you mentioned, both challenges that can be applied in MSF settings. I think that using a stepwise approach seems to be a useful strategy that could be used in all settings. Thank you so much for sharing your valuable experience. Next, I have the privilege to introduce Tasmin Botha, a mother and the executive director of PrimiConnect South Africa. We're honored to having you here, to hear her perspective as a mother and the impact that zero separation has in the parents of her association. We will all welcome Tasmin. Over to you.
Good day, everyone, and thank you so much for having me. It's such an honor to be here today and engage with you. My name is Tasmin Botha. I am from South Africa, and I am a Primi mom, as well as the founder and executive director of PrimiConnect. We are a parent-led organization that provides support, education, and raises awareness for families affected by prematurity. When my middle son was born at just 28 weeks gestation, weighing in at 108 kilograms due to placenta abruption, my whole world was turned upside down. I was thrusted into a world that I knew nothing about. Nothing could have prepared me for what a premature baby looks like. He was literally skin and bones, as fat as one of the last things to develop in utero. I was so scared and did not want to get attached to my baby. I was trying to mentally prepare myself for losing him. However, after a roller coaster 54 days in hospital and many different diagnoses, I was able to finally leave with my baby. I found once I left the safety net of the hospital, I still required support. I went in search online for a support group, specifically South African based, and could not find any. And this is how PrimiConnect was formed. When the COVID-19 pandemic hit and countries started going into lockdown, everyone became affected by not having access to loved ones in hospitals. This ripple effect was, and unfortunately still is, affecting the most vulnerable patients, small and sick newborns. I am proud to say that we are a part of GLANCE, the Global Alliance for Newborn Care, which is the global parent and patient voice in the maternal and newborn health arena, representing babies born too soon, too small, or too sick. And we implemented the Zero Separation campaign. Quickly, evidence-based research was conducted to show the detrimental short-term effects of having parents separated from their babies, as well as the long-term effects, some of which will only be seen in years to come. A report was conducted to see just how many families were affected by being separated and what effects that had. And let me tell you, the numbers are astonishing. Overall, 1 in 5 parents, which is 21%, answered that no one was permitted to be present with their infant receiving special or intensive care. 74% indicated that the mother was allowed access, with only 54% allowing the father access. Even in our local context, policies differed from institution to institution, with the majority having zero access. A few allowed for 15 minutes per day, and only 1 parent was allowed to visit in those 15 minutes. Mothers were still expected to provide breast milk during this time, and as you know, breastfeeding rates are low worldwide. The pandemic made it worse. My preemie was born before all of this, and I still clearly remember just how heart-wrenching it was leaving my baby every day. And this was after spending plus minus 10 hours a day with him. So I could absolutely empathize with parents across the world who had zero or limited access to their babies. Even within our own premature community locally, parents were meeting their babies for the very first time upon discharge, or for those who weren't fortunate enough to take their babies home once they had passed. Having your baby born prematurely is in itself a traumatic experience, but not being able to see, touch, or speak to your baby for the first few weeks, sometimes months, or even never at all, is something that should never, under any circumstances, happen. It is an already difficult process trying to bond with your premature baby. There are so many rules, so many regulations, so many risks, as well as all the financial, emotional, and physical burdens you as a parent are going through. I know I was extremely scared to even look at my baby after seeing him for the first time. Nothing in this world can prepare you for that. But by having full access to my baby, by being involved in his care, it not only helped me, but definitely helped him and assisted him in surviving and thriving. Our team was amazing at allowing us to be parents. But not only that, we were at the center of his care. We were treated as an extension of the medical team. They recognized that by having us involved, it not only gave us the confidence that we needed, but helped our baby to thrive. We were allowed to change his nappies and do all his feedings from tube to cup and eventually direct breastfeeding. The research of FICARE, which is family integrated care, shows that it decreases parent stress, results in fewer infections, improves infant growth and breastfeeding rates, and improves patient safety, which was our exact experience. With zero separation, parents are able to implement kangaroo mother care, which evidence-based research now shows should be implemented immediately after birth. When mother is unavailable to do KMC, the father or an extended family member may do so. The first time I was allowed to do skin to skin, my body responded immediately and my breast milk supply instantly increased. As time went on, I became more and more confident and was even allowed to do skin to skin whenever I felt comfortable. It gave me confidence to pick up my baby with all the wires and place him confidently on my chest. We were eventually admitted into the kangaroo mother care ward, and although our stay there was very brief, 40 hours to be exact, it gave me that extra boost of confidence that I required to be able to take care of him on my own. Separation can result in long-term health and developmental issues in newborns and impacts the mental health of parents. I have witnessed this firsthand. Becoming a parent is hard enough, but it's even more difficult when your birth is traumatic, unexpected, and your baby is born too soon, too small, or too sick. Just by keeping mother and baby together, we can eliminate so many and sometimes unnecessary complications. By implementing zero separation, we are keeping parents and babies together, and we are ensuring a better start to life and a better quality of life.
Thank you, Tasmin. I don't have words, to be honest. I have goosebumps in my, very, very emotional. Thank you for taking us through your intimate story. I think your experience illustrates clearly that parents cannot be visitors, but you are essential actors and partners for the care of their baby. So as you say, let's give them a better start in life. Now, we'll go to the panel discussion, who will be moderated by Dr. Kirli Polnai, a former MSF nutrition advisor who is currently working at WHO in the Nutrition and Food Safety Department. Over to you, Kirli.
Hello, everybody, and thank you so much for inviting me on to moderate this panel. As Sophie said, huge goosebumps, just so important, all the discussions we've been having. I'm just so happy that we're discussing this in MSF and that we're really sort of pushing boundaries. So we'll be having all our fantastic speakers back to the panel, and also two new panelists will be joining us. We have Livia, who is joining us from Brussels, at one of the headquarters in Brussels, Livia Tampalini. She has been with MSF since 2006 in the field as a doctor, as medical team leaders, as medical coordinator. And since 2019, she's been in HQ and working in the operations covering East African and Haiti. We also will be joined by Honorine, who is a registered nurse, trained in Rwanda, has worked with MSF also for many years, and has been very much pivotal, involved in KMC as her role as a nurse and also as a medical team leader. So welcome to you all. Thank you so much for being here. Now, I'm going to start off with some questions and to our new panelists, just to give our speakers a little rest. But I'm going to start with you, Honorine. Now, you have been working in many countries with MSF in many different projects. So from your viewpoint, how do you see, where do you see we are, in fact, for family-centered care in MSF? Where are we?
So thank you very much. As you said, I'm Honorine. I'm currently medical team leader with MSF. I've been working with MSF for 5 years. I started in Haiti as a pediatric nurse. So I was working in a KMC ward. And I went to Central African Republic as KMC implementer. So where we are now as MSF, so I would like to thank MSF because they gave me opportunity to implement KMC in Central African Republic. It was quite new. So when I started in the two projects, Bosangwa and Ibambari, it was new when I was talking about kangaroo mother care. Some of staff, they were even calling me Mama Kangaroo because yeah, it was a new topic. So when we started, before they were mixing babies and other children. And then we started like separating babies. And after we negotiated with a medical director, because it's MOH hospitals, and then they gave us the room. Yeah, but the idea came from MSF. And now where we are now, we have rooms for KMC, at least with 10 beds. And then now we are also in the health centers and the community level, where we are training mothers. So during antenatal care consultations, because where we are in the car, we are referring mothers, they are coming on maternal side. Yeah, so they have to put babies on KMC when they are being referred. So now kangaroo is being plugged in the community at health centers levels and in the hospital. Yeah. that is where we are. So, so now kangaroo mother care is no longer the topic for medical staff only. And now health promotion team, they are trained. So we are also working with mental health team, because when the mother is practicing kangaroo mother care, it takes time. And some of them, they even get like depressed. So we have mental health team, which is like coming every day, passing in a kangaroo mother care ward, so to talk to mothers. Another team is IPC team, where we are like working with mothers. We are doing like sensitization about hygiene, personal hygiene. And another thing also, we are like involving other family members when the mom is seriously sick, so the father can practicing kangaroo mother care or another family member. So it's no longer kangaroo mother care. Now sometimes we call it kangaroo father care.
Perfect.
That is where we are in Nika as like low income country.
Thank you so much, Honorine. And I really love that you're bringing in the importance of the health promoters and the mental health staff, our IPC. We know that we need everybody involved in KMC for any pediatrics or any nutrition project. So that's such an important element, I think. Next, Livia, coming to you. How do you see kangaroo mother care fits with our values as MSF as a whole? How do you see that?
Thank you. Well, of course, for me, this zero separation that it's definitely is fitting with our value. It's when we, as MSF, we want to be a medical organization, and we want to see the patient 360 degree and understand where it's coming from. But of course, imply that the patient is not only a little baby, but his baby is coming from a family. And this is inside of, for this that I like this strategy, this idea of zero separation. I think is we need to be, as MSF, a pioneer on this, because it's we believe to be a medical organization who is challenging and find a new solution. There are the zero separation and the immediately kangaroo, I think is nice also because it's affordable. It's not only for our following our value, but it's affordable everywhere. And everywhere we can ask the mother to stay with the baby far more than any kind of fancy biomed solution that we can find. That of course were a good solution, but a mother or a father or a family member is far more affordable in the context where we are working. So it's for me it's also important because it will fit in the fact that will shorten the bridge between the medicine that we are doing in poor country and the same medicine that we are doing in other country. And then also wherever we will be, we can propose. I'm not afraid to propose in the middle of nowhere in the same way than in a place where I can find doctor and nurse without issue. So yes, definitely, I think there are so many points that are fitting in our strength, in our capacity.
Thank you, Livia. Thank you. I think that's really, when you were saying about it made me think about the sort of real founding sort of principles of MSF and proximity, and this just reinforces all of that. And that equity aspect, I think we all feel that so strongly, trying to move closer to what we can provide for infants in high income settings and low income settings. And I think that's so important. So next, Barbara, I want to come to you. You did talk about this a lot in your presentation, but sort of tell us again, sort of we've seen that this family-centered approach, it's going to be a bit of a mindset change for quite a few healthcare providers, and a little bit of away from maybe the doctor knows best and the doctor knows what's sort of best for the child, the family. So in your experience, what have been those sort of points of resistance that you felt from some health providers, and how is the best way to overcome these?
Thank you for your question. The truth is that it's very difficult to change how you work with your patient when you have been doing your job for many years. In my unit example, several nurses were reluctant to let her perform some of the typical tasks, and they felt coming by them. So,
Barbara, we're losing you quite a lot. You're cutting out quite a bit. I'm just wondering, maybe we love seeing your face. Maybe turn off your camera just for a second so that we can hear you, unless we've lost you completely. Barbara? It's breaking out a bit, but we can come back to you, Barbara, or just try one more time for us.
Okay.
Oh, we can hear you.
Yeah?
Yes, go again.
Sorry. I think that it's very difficult to change your patient.
Barbara, I'm so sorry. We're cutting out. We're cutting out. Save that thought. We want to hear it. I'm going to come back to you. Okay. And we'll see if there's anything we can do from our end, but please save that thought. Next, I just then want to come to Naomi. You know, you were involved in this trial. You saw a lot of the healthcare providers being involved, and maybe you had to sort of train some people for the study and for the work. Tell me, what kind of competencies do you think we need from healthcare providers to be able to practice this family-centered care?
So the competencies that we might need, first of all, we need to train our healthcare providers, including the nurses and the doctors and everyone at large, whoever is going to be involved in taking care of these patients. All of them need to be trained, and involvement of the mothers and whoever is going to assist, whether it's the father or their relative who is going to be there, also need to be trained and need to be educated on the importance of family-centered care. And yes, it was a challenge initially, because it's a new thing. You have to educate people, you have to tell people the importance of immediate kangaroo mother care, the importance of involving the mother right from the beginning, the importance of zero separation. But later on, it gained access and people understood and nurses understood. And then it became easy for everyone to partake and help the mothers, and the mothers were free to talk to the nurses, they were free to ask, they were free to do to help the babies, and even the surrogates, whoever came to assist. Initially it was a problem, but later on when we explained to them what we were doing, it became easy for them to accept easily.
Thank you, Naomi, thank you. Tasman, I want to come to you now, and again, just echoing Sophie, it's so great to have a parent representative here. We're so appreciative, and so many things you said, and also listening to that mother, the video was talking about, I want to know every step of the progress with my babies, and I think that's so important. And what you were saying as well about being sort of too scared to pick up your babies when they're so little. I mean, I've had the same experience with mine, and that fear is very real. You've mentioned this a lot in your talk, but tell us again, because we can never hear this enough. What are those really important elements in that relationship between healthcare providers and parents that need to be there to make family-centered care, to make zero separation happen?
So I think, once it is established that the parents are at the center of the baby's care, that they are not just visitors, it automatically just opens up the gates of communication. And that's what I found in our experience. Like they saw that we were interested, they saw that we wanted to learn, and so it just made it more easier for them to integrate us into the care of our babies. And we were part of the team. I mean, I remember there was a situation whereby as it happens in our country, there was a huge strike. And I was like, okay, if there's no nurses coming into work today, I've got this. I can help them. I can jump in where need be. Because of the education that I was given, because they spoke to me as part of the team. When I didn't understand anything, they would explain it in layman's terms so that I could understand. So we just need to get over that barrier of doctors on one side, parents on one side. Once we realize we are a team, because we all want our babies to survive, we all want the babies to go home thriving. That's the common goal. So as long as we understand that we are not in competition of each other, or that one is more important than the other, I think the way forward looks very promising.
Thank you. That's great. So it's really, you're saying there's that sort of the trust element, really seeing and an equal, really being seen as an equal, being seen as a team. So that seems very, very important. And also, as you were saying, that really important element of explaining things in layman's term, not sort of hearing lots of medical terms and parents not maybe having the confidence to say, I don't know what that means. So that's a really important point. And then leading on that, Barbara, I don't know if you're able to give us a little sound test.
Yes.
Can we hear you?
Here.
Let's try again. Look at Barbara, she's right in the thick of it. She's got her scrubs on, she's in hospital. So just coming back to you again, I've got two questions for you now. You went away and now we've got two questions. So my question for you was about the points of resistance, and that you were sort of saying, we know it's hard changing our ways, but talk to us a bit about that.
Yeah, I was saying that the truth is very difficult to change your job, because you have been doing the same job for many years. And for example, in my unit, the main issue was that several nurses were reluctant to let parents perform some of the typical nursing tasks, and they felt examined by them. And some of them didn't understand their role with the family, with that families, and with the family integrated care model. For this, it was essential to carry out an initial training and also an annual training to refresh the importance of the parental participation in the care of their children, and how we can guide their families and their training as facilitators. Because it's important to explain that we are facilitators for the families, and that our work continues to be very important, but the role is changing.
Thank you so much. But I'm going to keep you, because we've got you again for another question, which I think you'll be able to talk to us about, and especially seeing how you were talking about having mentors. So, we've talked about the training, but how? What's the best way? We know sometimes, didactic training and your PowerPoints, but how do your mentors help? How do we have that sort of bedside approach? How would we bring that?
It depends on the unit or the group of people, but in general, I think it's a good option. The first part of the training, a theoretical part, like e-learning or similar, and after prepare different face-to-face sessions to discuss the doubts or the different questions about that training, because it's important, the communication between the different people, and is the essence of the family integrated care. For example, in my unit, we are doing every year a refreshing about the training. Now with the Rising Family project, we did e-learning, and after that, face-to-face session to discuss about that.
Thanks, that's great. That's really, so e-learning reinforced with sort of face-to-face learning, that's fantastic. So Livia, coming to you, putting your operations hat on, I'm sure you're listening to this and thinking some of this is great, but what are the sort of barriers as well? Or what are these obstacles that you're thinking, could we do this here? Could we do this there? What's coming to your mind in terms of barriers? And then of course, I won't let you off, because then I want to think, what are then a few solutions to those barriers? Oh, Olivia, you've frozen. But she's frozen with a nice smile, which is always good. I shall then...
For us, as
you're back. Olivia, we lost you for a minute, so just give us the last sentence back.
Sorry. I was saying that first of all is the knowledge, because we have to do like the other hospital in the world. As MSF, we are a medical organization, and we have to be sure that all our medical staff is aware and is trained of this. So this, and I'm not so sure that we are doing. I'm less optimistic than Honorine. I'm not so sure that we are really 100% on the zero separation. This I'm quite, I have quite doubt, at least for what I see. I think at least in our mission we have to improve. I have to avoid. So it's maybe already put me in this panel, push me to study. So this can be one of the solutions, that I will push everybody to study and to force and be trained on this. I'm not able to see how many participants are on this section, but this can be one of the answer to your question, Kirill, to know how many PMR or medical referent or medical coordinator are participating to the pediatric day, not only on zero separation, of course, but this can be one of the solutions for MSF. So like we were saying, training, mentoring, e-learning, coaching is a culture that we have to continue and to build in MSF. And then yes, the issue for me is that is as usual we work as a silos even in MSF. So it's if in the medical department we are speaking about zero separation, but then we have to speak to involve everybody on Jesus, the ops, the log. I know that in the log construction book there is already the zero separation, but then when in practical we are going to design an hospital, we have to be ready that this is existing really, that is not only on paper, but in reality we still see little bed, no mother, no space for the mother or the family behind or together. So it's I think I'm not so sure. I think we have really to start from far, and for me the solution is really, first of all, like someone will say, work as a team. And remember that in MSF we are a team, and if you are not a team, we will not go anywhere. And then really the culture of learning. That is we cannot believe that what we learn when we start MSF is what we still have to do. We have to learn every day, every year, and I think voila, this is also a nice opportunity to learn. After, for sure, there are a lot of other steps, and definitely starting from the HQ, I have to say. It's has to start from there and then going to the team in the field and go away in the other way around, up and down, and right and left, and to see what are the challenge, because I'm sure definition of family and family approach is not the same everywhere in the world, and we have to adapt in the niche context in a different way. And for do this, we have to listen our team in the field and find our own solution that for sure will not be the same everywhere. But this is we have to be ready to this challenge. Voila.
Thank you, Livia. I think, yeah, that's, I think as medicine changes, and I think that's really important, isn't it? That we all have to stay up to date, and also to, you know, I think about back to my first mission and how I progressed and changed, and we all have to keep doing that in MSF. My next question is for you, Naomi, and we sort of thought about, well, we talked a little bit about sort of maybe some task shifting, and so it can kind of go both ways, isn't it? And that we don't want sort of, you know, some things that doctors or nurses traditionally did. Like, so what experience did you have in your hospital about task shifting, or not necessarily shifting, but sharing of tasks that can really facilitate zero separation?
So it was a bit of a task initially, because we had to train before starting the project. We had to train the nurses about the importance of zero separation. And initially, because we also didn't have CPAPs, they came a bit later. We also had to train them about the equipment, about the use of nasal prongs. So a lot of trainings had to go with the midwives, with the place of delivery, the labor rooms, in the theaters. And we had also to train the doctors that were also working in the unit. We had to inform them and tell them about the study, and we had to tell them about the importance of zero separation and importance of babies undergoing treatment while they're on their mother's skin to skin. So eventually, with time, people started understanding. Initially, it was difficult. People were scared, but later on they understood, and then they felt, okay, so this can be done. A baby who is sick can stay with the mother or the surrogate and still receive the same care that was needed initially. And if the baby was very sick, needing further care, yes, we would separate for that particular time, and later on she or he will return to the mother. So it was kind of a hard task, but later on we got the move of things.
Great, thank you, Naomi. I want to talk a bit about the continuum of care. So Honorine, you mentioned this a bit, but talk to us a bit about and how your experience have been of trying to implement zero separation or even in KMC at a sort of community level in health facilities or beyond. Tell me a bit about the work you've been doing there.
I'm sorry, what we are doing now at community level? I'm sorry.
Sorry, that was for Honorine. Barbara, I will hear from you later, but first Honorine, and then I'll come back to you, Barbara.
Yeah, so now what we are doing?
Yes, in the community, you talked about it a bit just earlier on, but so just tell us a bit about how you really managed to get this, not just in hospitals, but as in health facilities or sort of in the community. You know, what's made that work and what has made it not work?
Yeah, so as I said, I was implementing zero separation in a hospital, but we were receiving many premature babies and the other babies, of course, who were coming from the community. So we don't have cars in a rural country, in a low income country like car. So we have outreach team, we have a health promotion team. We trained them as, of course, we are working as a team. And because the team of outreach, we have nurses, we have midwives, and now they trained the community, traditional birth attendants. So they are the ones who are still referring babies. Of course, we are facing many challenges. Many babies are dying on the way to the hospital, but at least when we started comparing where we are today, at least we are saving 50, like 70% are surviving. And we always evaluate, at least every month, we evaluate where we are and where we want to be. Yeah.
Thank you, Honorine. I think it's a bit of a reminder, you know, that lots of these kids are dying on the way, but the fact that you are trying is fantastic. And then Tasmin, talk to me a bit about what are the differences in messages, or what are your different needs when you're in hospital versus having this kind of zero separation support at home if somebody's coming to you, or you're just going to sort of a more of an outpatient setting. What are your needs there, and what do you maybe see we need to do more of at that level?
Definitely, you know, prematurity is such a taboo subject still, unfortunately. So education is definitely key. Knowledge is power. If everybody on the ground understands the risks involved with a preterm child, you know, just general hygiene, simple things like that makes the journey at home so much easier. You know, when I think about when we were discharged, we went into complete isolation just because we were so afraid of bringing our premature baby into contact with people. And people were so very, very stubborn with regards to educating themselves, respecting our boundaries, our needs, simple tasks like washing hands and sanitizing, not coming around when you're sick, were such challenges for us back then. And I feel like the more we educate people, the better it will be, because I've seen the shift now. I mean, the COVID pandemic, as terrible as it was, actually opened a lot of minds to simple tasks like washing of hands and sanitizing and not coming around when you are ill, because of the detrimental effects it can have on a child that is born prematurely. So, I mean, at antenatal level already, would be nice to inform the parents, should you have a preterm child, this and this and this should be put into place and should be done once you're home, because like we're saying, like the mortality rate post-discharge is so high, and I honestly believe it's due to lack of education.
Wow, that's so interesting. And when you were saying about this sort of education, it kind of goes then beyond even sort of health facilities or even the family, because you realize it's your family and your friends who needed the education. And so if you kind of, what would be the best tool that you want of educating those people around you to your needs and about the sort of the realities, the do's and don'ts of premature babies? What would be the most useful thing if you could kind of have it today in your hands? Is it an app? Is it a TV program, radio program? Like what do you think would be useful, or a little information thing?
I think it would differ from place to place, just because access is so different everywhere. Like it's easy to say, oh, an app, but like, you know, in Africa, getting data or even having smartphones is not very accessible for many people. So I feel like a lot of people definitely, they go to clinics. We have to go to clinics for checkups. So let's start there. Let's have a pamphlet, a brochure, people coming in to give talks. I mean, I was very, very impressed with my last pregnancy, that they did speak about premature birth, that they did educate about some signs and some symptoms, because we know that premature birth, you know, it's up and down. It's not one size fits all, but to at least know, okay, there are indicators, you know, if my blood pressure is too high or things like that. So if we can just let people know from ground level, like this is a thing, it's a real thing. Prematurity is affecting so many people. And we've seen an increase, you know, through this pandemic as well. So if we start just at the bottom and work our way up from there, we can go into fancy advertisements and stuff, but let's start with clinics handing out information. I like how Honorine was saying that they had outreach programs in the community. That would be great. You know, finding out about prematurity when you have a premature child is not the ideal situation. I would have loved to have had information prior, you know, like my premature birth was a very unexpected, as is most. And then you thrust it into this world that you just absolutely know nothing about. And I mean, I'm 5 years into this premature journey, and I can tell you till today, I'm learning every day new things about prematurity. So if we can just provide tools and access and education. I mean, I know it's easy for us. We can go onto a phone, we can go onto Google, we can type in some, but not everybody has access to that. And we need to make it easier. And so that we can also educate the generations before us, because they are also very resistant, especially in the African context, like our grandmothers and great-grandmothers who end up being the primary caregivers in a lot of circumstances. They don't want to hear about these things. So we need to be able to educate them as well in a manner in which they would understand that, you know, if you do A, it's going to lead to B. We need to not do, you know, these type of things. So yeah, we just need to educate and start at the grassroots level.
Thank you. That's a really powerful message. I hope everybody's listening out there. Now, we're going to go now to some of the questions that are coming from our audience. Lots of great questions coming in. Thank you so much. Keep them coming. We will try to answer as many as we can. So one of the first ones that's come in that everybody's very interested in is IPC, of course. So infection prevention and control. Barbara, let's start with you, and then I'll ask the same question to Honorine. But did you get pushback from IPC? You know, how did you address that issue? And sort of what were the things you did or the discussions you had that helped?
With family integrated care, we have demonstrated that we have less infection when the parents is the main caregivers of the babies. Obviously, the healthcare professionals, we are very, very worried about the infection, and many people think that it's worse if the family is included inside the neonatal intensive care unit, but it's not true. The truth is that there are less infection when the families are inside our units. Obviously, they have to learn about the hygiene, and they have to learn about what they have to put, to dress. But obviously, we can't forget that our patient is not only the baby, it's also the family. If you take account the family also is different, and in the infection is aware of the objectives in this type of model like family integrated care.
Thank you. That's really interesting. So infection rate is lower when families are involved. I think that's a really important message here. So the same question to you, Honorine. What discussions have you had with your IPC colleagues? What have been the sort of difficult discussions, and then the sort of agreements that you've come to be able to carry out zero separation, family centered care, and KMC in particular?
Yeah, thank you. So for us, we worked as a team. We included everyone because it was new. Even we had the support from ops, the PC, logistic, and rep. So for us, yeah, what we did, we trained everyone first, the guards, medical staff, logistic team. And then it's not everyone who is like allowed to enter KMC ward. Yeah. So we have the guard who's controlled the movement, and we have also dedicated team for cleaners and hygienists who are trained in IPC. The same for medical staff. And then we even requested, the dress code for mothers. We have dress code for babies who are in KMC. And then we have, to clean the ward at least 3 times a day. So we have instruction for KMC. Of course, we had challenge because it was like starting from the scratch, it takes like, 3 months to convince people how to behave, that we don't have to enter the word KMC with our own shoes, because there was gloves dedicated for KMC. But now I would say that we are at least at 80%, and then we continue to reinforce sensitization. We are working with health promotion team. We have a health promoter dedicated for KMC ward who is sensitizing everyone. Yeah, wash your hands. Even it's not only for mothers or like visitors, even for medical staff, we have always to remind them. Yeah.
Thank you, Honorine. I think you're reinforcing as well what Livia said, the importance of being a team. Now, one question which has had lots and lots of likes, and it makes me hope that we've got some logistics people watching, but is how do we, so I'm going to ask this question, Naomi, to you first. How did you involve, the logistics or the facilities people in your hospital to help with creating a space that you really could do zero separation or KMC? How did you talk to your logistics colleagues?
Yes, so in our facility, there was a room that was given to us once we told them the importance of zero separation, and once we told them about the study, and once we educated everyone. So a room was allocated for us. In that room, we had 8 beds, and there were 8 CPAPs, and then we were able to recruit mothers, but then since it was a randomized control trial, we had to first consent, and then they were given a card. It all depended on what arm they were going to fall on, and then they were recruited consecutively. So we had a good support from the head of the hospital who gave us that room, and then it was renovated, and then the space fitted what we wanted to do for the study. And truly, we saw great reduction in mortality, and even hypothermia had improved, because we were taking these babies as the time they were born in theater, the time they were born in the labor rooms. We had already educated the surrogates, even though there were times they were not understanding. Being in Africa, they had so many notions, but later on they understood the importance of taking care of these babies right from when they were born. So we saw there was a reduction in hypothermia rates, and then there was a reduction in sepsis, because we educated them again about the importance of IPC. And at the same time, the survival rate had also increased in the first 72 hours of all the babies, and even though at the end of the study, which was 28 days follow-up.
Thank you. That's really interesting. So maybe we can sell the idea to our logisticians by saving on heating bills, maybe. But just Livia, coming to you, put yourself in the position being a project medical referent, or being, a medical team leader of a project. Tell me the discussion you're going to have. You're going to knock on the door of the logistics office. How are you going to sell this? How are you going to get them involved?
Well, first of all, I think it depends when in the project we are, in the history of the project. If you are at the beginning, so in the construction moment, or if you have to make big changes. Because I think these are the important things to remember. At the beginning, I think it's in one side is easier, but it's a big, because usually we sit together and we speak and we make a plan and design, and it's easier to have a better flow of patient, a better organization. If you have to make a change, it's, well, first of all, it's always, again, is a teamwork. An hospital meeting cannot be only the medical team. And this will never work. This we have to be clear. It's to be, and medical doesn't have to be only doctor and nurse. It has to be HP, it has to be mental health, and everybody has to be convinced. But I think it's, for me, it's clear now that we were doing the same this discussion for an hospital in our project, and I think if the people doesn't see what we are speaking about, they will not follow. Once the log, in my experience, once the log understand what you want to do, then the things is done, and maybe you will find even better solution than what you were thinking as a medical team. So just really explain. A picture for me was already easy, or when I ask explication about what is really zero separation, I was trying to challenge and say, okay, even this child, yes, even this child. So for the log has to be the same, has to understand all the children, yes, almost all the children. So it's okay that you have you need a big bed and voila. But this is together, and don't be scared. Don't scare the people to make the stupid question. I think this is also the key of the explication. I was not afraid, not too much, to ask the stupid question when I ask me the explication. So it's I think it's the same for everybody. It's allowed everybody to make the stupid question, and then we will be a team who understand.
Thank you, Livia. There's no such thing as a stupid question. And I think that's a really important element for our logistician colleagues, for our supply colleagues, is come with the problem. Don't always come with what you think the solution is going to be, because sometimes other people will be thinking in a different way, and maybe kind of out of our little medical bubble, they will come up with better solutions. So another question, which is really interesting one. So I'll ask this one first to Barbara, but then I will come to you, Naomi, as well from the study, is that if this approach has had any effects on the rate and sort of nature of perinatal or postpartum mental health outcomes. So I don't know if, Barbara, you managed to capture that information, or just even anecdotally from the people you've worked with. What's been your experience?
In my experience, the families who can care their babies, they are very, very happy. They have more confidence, and they are prepared to go home, because they have studied, they have trained, and they are prepared for that. And obviously, if you explain everything around the care of their baby, they are more relaxed. The depression and anxiety is lower, and that's important in this type of units, because it's very, very stressful to have a very sick baby or a very premature baby, and we have to try to avoid that psychological disorders. And if you can achieve only include the families, that's great. It's easy.
Thank you, that's great. And Naomi, I'm not sure if that was collected in the study or not. You have to forgive me for not having read that part, but did you collect anything on sort of quality, the experience of families, or even sort of any effects on postpartum depression or mental health status in your study?
No, it wasn't collected, but the few mothers, I mean, most of the mothers we spoke with at the end of the study, whenever they were being discharged, whenever we asked them, they were really happy. They enjoyed the fact that they could be with their babies. They saw everything that was happening to their babies. They understood the treatment that the baby was taking, and it was easy for them to explain even to their relatives of what was going on. And we saw that it gave them like a calming effect compared to the control group, because we would go and see, they would come in hours, like every 3 hours or sometimes every 6 hours to come and see their newborn. But these ones, and the control group would sometimes say, I wish I was also in the other arm where I could stay with my baby all the time. So really, we saw a great improvement and a great calmness. And I think because they could initiate breastfeeding early, they were able to do everything for their babies. Yeah.
Thank you, Naomi. That also speaks to this element I did see from your study that was actually stopped early because there were such important benefits. And it makes me think of you saying about this sort of the mums in the control arm, how difficult that must have been. Another question that we've had in is about the surrogates, which I think is very interesting. A few people have mentioned them, but I wanted to start first by putting this to Tasman. How would you feel about somebody else doing this, about somebody else doing the KMC? I know it will depend on who it was, but, you know, and how would you feel, Tasman, about somebody else giving that care to your baby if you weren't able to?
Well, knowing what I know now, obviously with the information that I've received, absolutely I would allow somebody else to do it because the benefits are just so great. But obviously that would need to be explained. You wouldn't just want somebody, here's the baby, you know. But yeah, if the benefits were to be explained and you knew that was the best for your baby to survive and thrive 100%, I would definitely allow it.
Great, thank you. And Honorine, coming back to you with your kangaroo father care, tell us about how you've involved surrogates, including fathers, in this process, and what did you know, what was the best way to get them involved or get them to accept it, and obviously the mothers as well to accept it?
Yeah, so first of all, you have to know that the context where I was, you know, the mother is always coming with the father. Yeah, most of mothers, they are coming with the fathers. So when the mother is seriously sick, or maybe the mother has twins, yeah. So we started like explaining to the father the importance of kangaroo mother care. Yeah, the importance of zero separation. And then I would say like 90%, they accepted without hesitating. And I said before, we even included the mental health team. They were talking to the father and to the mother, and because of culture barriers, when they will see the father, like, you know, carrying baby on the chest, what they will say, yeah. So, but the mental health team helped the team, the medical team, yeah, to handle that issue. And the fathers, I think, even if I'm not there, they are still practicing kangaroo father care. And we also like asked them the consent to take pictures, and we have like some pictures in the ward, and sometimes we even show the new fathers, look here, you are not the first one who is doing this. And we are also, we are doing the same for mothers. We have many pictures, we show the mothers, look, the previous ones, they did this and then baby survived. So can you do this also? Yeah. We are taking pictures before and after when they are coming back for follow-up. Yeah.
That's fantastic. That's a great idea. I really like that those pictures ideas. Now I'm gonna have one question, and then I'm gonna from the audience, and then one final thing I'm gonna put to Tasmin. But this is a lovely question here, which, you know, gives us the spirit of debate in MSF, which we know is everybody loves. So this is this. Given the clear benefits of keeping mothers and babies together, we might wonder, why did we ever separate them in the first place? Should we even do neonatal care if we are not able to keep mothers and babies together? Now, of course, I'm just going to ask that hard question to Livia. She knows that was coming. So Livia, should we even be doing neonatal care if we cannot keep mothers and babies together?
I will answer with a question. Why we should not be able to keep together?
Ah, very good. You can see she's
I get it. You know, I mean, it's a question of space, but we are in MSF, so we can add a tent. And I think then the fancy part will. It's for this that was what I will say, that for me is quite sustainable as a part of the project. So the question can be what we are not able to add as additional care to the baby, oxygen or additional things. That this is okay, but this is always the question. But keep the baby with the mother or the father. It's a question of space only, and anyway, you will not kick out them of the hospital, I hope now, and then it means that are somewhere in our compound. So I think it's only here in the mentality, and for me it's a question, and it's for this it is important that we change. But the reason is only why we don't have the space is because we didn't put it. Yeah. Only this.
Well, I like that. Why couldn't we keep them together? Now, just want to say a big thank you to all the panelists, but I do want to have one last thought from our mum, from Tasmin. Tasmin, if you literally had one sentence that you just wanted to leave this session and for MSF, what's the one short sentence, but the powerful message that you want to give to MSF and to everybody listening to this? No pressure.
Definitely that by keeping babies with their parents, they will survive and thrive.
That's enough for me. That's fantastic. Thank you so much, Tasmin. Thank you to all the panelists. We really appreciate your thoughtful answers, and we really think you've given so much food for thought. So I will close our panel discussion and hand back to Sophie. Thanks so much, everybody.
Thank you, Kirli, and thank you all the panelists. I'm really speechless. I'm super happy to hear that Operation is saying there is no way we cannot do this. We need to find a way to do this. Thank you, Livia, for representing the operational aspect of MSF. So I have the big job of trying to summarize quickly the main messages of this session. So I think it was clearly during the panel discussion, during the presentation, that one, mothers and babies needs to be together right from birth. With a zero separation approach, we will revolutionize the care we provide to newborns, because it will allow us to implement a life-saving intervention such as immediate kangaroo mother care. We saw that there are many opportunities to implement zero separation along the continuum of care. Family-centered care leads to better health outcomes, improve experience of care, and empower families. We have seen it and we heard it from Tasmin Bota. However, we still have a long way to go in our fields. We need a cultural shift. We need trainings, but not only trainings, we need to change the way we perceive the problem. We need to involve all stakeholders to ensure a successful implementation of family-centered care and zero separation concept using different strategies. approaching the different challenges that will raise from a multidisciplinary perspective, not only from the health staff, but also from other profiles. We heard that logs, HR, admin, community engagement are important. And finally, we need to engage with mothers, with families and communities to really overcome the problems when they come. We have heard that there is fears and resistance from health staff on the risk of increased infection, which are unfounded, because we have heard that the latest evidence show that infections are reduced when mothers and babies are involved in the care. So finally, let's remember, mothers and families are not visitors. We need to open the gate, as Tasmin said in her presentation. They should be active actors and partners in care. Let's give the most vulnerable patients the best start in life. Please spread the word and let's all start the change together. We need to start changing the way we see the problem. Thank you all. Thank you for the panelists, for the people behind the scenes who made this session possible, especially thanks to Ana de Losada and Marge Hodges, the SRH working group, and everyone for listening. Thank you. Back to you, Myrto.
Wow. Thank you. Thank you to everyone. Thank you, Kirili. Thank you, Sophie. And thank you to the entire team on the panel, all the presenters. This was just amazing, absolutely amazing. And yes, I hope this is just the start and it will not just be an amazing memory. So we are, I think, a little bit early, or can we move ahead? I think I will just move ahead and then we will see if we have some time at the end. We can pick up some of the thoughts that were talked about today, because I think some of them are really worthwhile repeating. So we have two more presentations now before the end of the day. The first one is an interview with Dr. Mani Mashako. Dr. Mani Mashako from DRC, who is a pediatrician from DRC with experience of over 20 years in DRC, in the Yemen, in Niger, Mali, West Darfur, and who has worked with MSF since 2019. And he's a strong believer in ongoing medical education to save lives. So this is very fitting to our topic here. Welcome, Mani.
Leur projet. Aujourd'hui, nous avons la chance.
We are going to try and answer this question today, thanks to Dr. Mani, who is with us today. He's going to talk about his experience. So, hello, Dr. Mani. Hello, hello. I'm very pleased to be with you today. My name is Mani Mashako. I'm a pediatrician. I've been working for the past 20 years approximately in pediatrics. I joined NMSF in 2019. For now, I'm a pediatrician on the El Janina project in North Sudan. Oh, well, we're very lucky to have you with us today. So, which pediatric days did you take part in? Well, the latest edition, the one in 2021, that was online, was the first online event, and I took part in all sessions. So last year, we discussed several issues, including tuberculosis, COVID. I assume you've worked in various contexts. So maybe you could explain to us how this is being useful in your daily work, how the sessions have proven useful. Well, indeed, various topics were tackled. For example, we heard about neonatology, back to the basics, to the fundamentals. They insisted also on breastfeeding. And really, this drew my attention because in Niger in 2021, on the ground, we were faced with a challenge. the increase in the number of children with a low weight, insufficient weight. And we had to really find a solution to this. And we based our work on the findings of the latest edition of the Pediatric Days. We set up an intra-hospital study in order to try and understand the root causes for this underweight. And we understood it was due to poor breastfeeding practices that had led to those insufficient weights. And this is how we worked in order to find a solution to that problem. Okay, very well. So, and did you have any challenges when you tried to implement a solution? Well, yes, indeed. First, we had to understand why we were faced with those low-weight children, and we did this intra-hospital study. And this really revealed that this was due to poor breastfeeding practices within the community. And within the hospital, we launched the double suction technique, and also we corrected those poor breastfeeding practices. We sensitized, we raised awareness amongst the community, amongst mothers and next of kin, and this is how we improve the situation. Well, thank you. This is indeed a very important aspect about community engagement. This is another topic that was talked about during the latest edition. Do you have any other examples of activities carried out within the community? Do you have any experience based on your participation in the Pediatric Days? Has this helped you lead to the adoption of new approaches? Well, yes, indeed. For example, community care models that can be adapted to the various needs of children. And we had COVID, obviously, which impacted various programs and the care given to children. Indeed, we were faced with an issue, a nutritional issue, and because of COVID, the program was impacted, and we launched an early screening strategy in children in order to detect malnutrition in children within the community based on the mama contribution. So we trained mummies in order to detect malnutrition early within the community using the observation of nutritional edemas, for example. And I'm sure that this will lead to long-term benefits. Well, thank you. This is a very interesting example indeed. I'm very pleased that we have had the possibility to talk about this during the last edition, and that this is being beneficial in your daily practice. So any advice, any piece of advice for future editions of the Pediatric Days? Well, MSF is an organization that provides answers to vulnerable populations, and those are evidence-based solutions. And in my view, those pieces of evidence are being discussed and presented during the Pediatric Days. It's a good time to improve our daily practices on the ground. This is why we would suggest that this activity is then adopted by the various medical groups and doctors, so that the people who take part in the Pediatric Days can then implement the right strategies in the field. Wow, thank you. This is indeed really interesting. I believe there's some work to do. So what can be done after the Pediatric Days, and how can we include all we've learned during those days into our work on a daily basis? This is the key aspect. There's also a key point about the Pediatric Days also to listen to colleagues, to hear about projects as you did today. So thank you so much for having shared your experience with us. And I wish you a very good rest of the Pediatric Days. And thank you very much to you. Thank you so much, Dr. Mani. Thank you.
Thank you. Merci, Dr. Mani. And with that, we come to our last presentation of this morning and of this day, of the first day of the pediatric days. And this last event is going to be given by Maria Belen Italia Cenere, who will give us a live demonstration on e-care. Belen, as so many of the previous speakers, is a pediatrician and neonatologist from Buenos Aires in Argentina. She has been with MSF for over 6 years now, and in the last year, she has been working remotely with a team delivering e-care. Welcome, Belen.
Hello, thanks for inviting us. I'm here to show a short demo on young infants e-care. First of all, let me do a short introduction on e-care program. E-care program started as a TIC program in 2019. Although e-care pet had already been running since 2016, e-care pet aims for children from 2 months old until 5 years old. That's why we developed e-care young infants in 2022 that targets the age group from 0 to 2 months old and also the mother's health needs. Now we're developing an e-care on vaccination that will be piloted next year. So eCare is an app that is used in a tablet that was developed using a community health toolkit platform that is an open source platform and that allows the health worker to connect offline, to use the algorithm offline. The algorithm guides him step by step through a syndrome-based consultation with the final goal of improving the quality of care. At the moment, eCare Pet is used in 6 countries in around 30 MSF health facilities, and MSF eCare Young Infants is aimed to be deployed in these same projects. We just finished the pilot on eCare Young Infants in Niger, and we are gathering the feedback to do some improvements before the final deployment. In an overview, eCare Young Infants covers the following topics. First of all, we aim to detect the acutely ill young infant. Then, if there's no danger sign present, we continue with essential care of the newborn. And if the mother is present, we conduct an assessment of the mother's health needs. Also, we assess the nutritional status of both mother and child. So I'm going to show you a short section of the algorithm. I'm going to connect via the web app, but it looks exactly the same as the tablet. Here you can choose the language, English or French, and we will have in the future the option of having it in Portuguese. In this page, normally you could choose from which algorithm you want to follow, if young infant or pet, but this was done for young infant pilot. That's why we can only see young infant. Here, the consultant chooses his profile. And in the initial page, there's some life-threatening conditions, such as not breathing, convulsing, unresponsive, and the initial management. So the health worker is guided step by step in case of a life-threatening condition. If none of this is detected, we continue to the registration page where you can enter the age in days or weeks, the weight, gender, temperature, and here in the temperature, what we aim for is to detect any abnormalities, the same as respiratory rate. So for example, if I enter 80 for a 3-day-old, the app will say that it's a very severe disease that requires urgent referral to the hospital. And it will provide the proper management. First of all, since we set up already that this is a malaria transmission area, it will prompt us to do a malaria RDT while waiting for referral. But this option can be turned off in areas where there's no current transmission of malaria. So the result of the malaria test, and now the treatment and management of the very severe disease. We need to know if referral is possible or not, because we provide both options. So if referral weren't possible, it will prescribe ampicillin and gentamicin, how to prepare and how to administer them, and then how to follow up. Schedule a follow-up in 12 hours for the ampicillin dose and the next day for the ampicillin and gentamicin, and what to do at each follow-up appointment. So now this algorithm is pretty comprehensive, and it can be pretty long or short, depending on the situation. I'm going to show some screenshots on other sections, such as this one, that is an essential newborn care consultation, where we ask for if this is the first time the baby attends a postnatal consultation, if the baby was delivered at home, and if so, how to administer the routine prophylaxis, and how to conduct a complete physical examination to detect any congenital abnormalities. If the mother is present, how to assess the mother's health needs, starting by the clinical problems such as infections, eclampsia, thrombosis, how to assess her nutritional status, and a quick screening for mental health conditions, aiming to detect postpartum depression and postpartum psychosis. Then the nutritional assessment for the child, it includes anthropometric parameters, and also if there's any congenital condition affecting feeding, how is the mother's attitude towards the child, if she appears traumatized or rejecting him, and how is the baby fed, and if it's by breast milk substitute, how is this prepared? Finally, all of the paths lead to a section on counseling, where we explain the caretaker how to take care of the baby, how to feed the baby, how to keep the baby warm, how the baby needs to sleep, how to keep him clean, and of course, what are the danger signs and when they need to return. So that's all. Thanks for your attention, and I hope you'll be using e-care young infants in the field.
Okay, thank you. Thanks, Belen. This e-care tool is really quite a help, especially in remote settings, and it can be really used for training as well as in working in the field with it. So thank you again, Belen, and thanks to everyone. This was the last presentation of the day, and you can speak to Belen about the e-care tool if you're interested in hearing more about it in conversations over coffee. Once again, you can just go to the button underneath, and of course, don't forget that you can talk also to everyone, or almost everyone, because I'm not sure if everyone will be there, who participated in the zero separation session, also in conversations over coffee. So please do that. We're running a little bit early, but I will just quickly try, before saying goodbye, wrap up a little bit some of the impressions that I have had of the day. It's quite, to tell you the truth, it's a bit difficult. It's quite daunting because the day has been, although it's just half a day, it has been extremely dense, and presentations have all been extremely interesting. Just a reminder of what we talked about in the morning. It was, well, maybe it was not the title of zero separation, but a lot of them had very much to do with zero separation. It had to do how to bring the mother and the baby closer together, about breastfeeding, how to create the environment around our health structures and our health care to support better baby care by including the mothers, by improving best breastfeeding, by providing spaces for mothers and babies to get acquainted and to get better outcomes. The presentation on early skin-to-skin care, okay, it's not kangaroo mother care, but it's very close. You know, there were a lot of questions about what is kangaroo mother care, what is skin-to-skin care. There is, it did show, talking about neurodevelopmental outcomes, that there is a huge benefit in having close skin-to-skin care for young babies right from the beginning over, and the benefits can be shown years later. So altogether, I would like to just talk about, come back to the very beginning. We said, put the child in the center of our care. While trying to put the child or the baby in the center of our care over time, we in fact forgot that we were putting the child in a silo. We're siloing the child away, thinking that was the best thing for the child, but eventually we're slowly coming back and integrating the child where it belongs, in the center of the family, the community, when it needs medical care, providing that medical care in the most adapted way. And when we say we want zero separation, not to think about what the problems are and what the obstacles could be to provide it, but to think, have a solution-oriented thinking, to know what is best and then try to find solutions for what is best for the people that are in our care. Words that spring to mind are trust, fear, empowerment, working as teams, and doing it step by step, and not trying to do everything perfectly from day one. It might not be possible, but at least have the right mindset and work towards it. And maybe last but not least, I want to say that when I joined MSF quite a long time ago, as some of you might remember, taking care of newborns was not on the agenda at all. The newborn really didn't factor at all in MSF's care. So I'm absolutely thrilled to be sitting here today, admittedly, a couple of decades later, and seeing that we finally have an entire day dedicated just to the newborn, and that it is not just something that happens in MSF, and that MSF is learning from what is happening outside, and the outside world looks at what is happening in MSF. So thank you so much for all the presentations, for all the enthusiasm. And I'm going to say goodbye for now and wish you a really interesting other 2 days. And just want to remind those who have registered for workshops that they will start in an hour after the conversations over coffee. And please check your email to find where you're going to meet in the virtual platform. To remember that there is a lot of interactive platforms that you can go, and you can go to the booths, you can go to the poster halls, you can go to the networking lounge, use the chat function. Don't forget to do that all. And once the conversations over coffee start in about 8 minutes, you can meet the presenters in the various chat rooms. So this was a wonderful and inspiring day. I'm already looking forward to tomorrow, and on prevention is better than care, which I will be able to watch as an audience, and Johanna will moderate. Okay, goodbye for now, and see you tomorrow. Bye.